Yes.
Yes.
We are live now, doctor.
A very good evening, everybody, and I welcome you all to this webinar by Young Ophthalmology Society of India, a society that was founded by Dr. Tarun Arora and Dr. Vijay Sharma in the year 2014. We have a lot of presidential working groups who works tremendously under the guidance of our office bearers, Dr. Devakant Mishra as the president, Dr. Sonal Kalia as the past president, Dr. Karan Bhatia, who is there with us today as the vice president, Dr. Nilesh Kumar as the secretary, Dr. Aditya Sethi as the treasurer, and Dr. Prasanna Viramesh as the joint secretary. And we have an executive committee of around 20 in number, and we also have some PWG leads who are doing wonderful jobs. So we also have a Yosi Cornea focus group led by Dr. Karan Bhatia and Dr. Aditi Ghosh Dasidar, where we have a lot of dynamic academic sessions. We also have many other Yosi focus groups as a glaucoma, pediatric, trauma, cataract, and then we have refractive, retina, and uvea. We also have a Yosi Career Portal team and a Yosi Navigator where we help you get into jobs and get into fellowships, understand them better. So last month we had a similar webinar with our glaucoma focus team where the mentors guided us through the glaucoma fellowships and the residency and the tips and tricks. So today I welcome you all to our cornea subspecialty, the Cornea Tech Unplugged, Learn, Lead and Inspire. We are very happy that on the behalf of the organizing team, it is my pleasure that we have the residents, fellows, and young ophthalmologists who are joining us today. So this webinar is designed to go beyond the textbooks and the surgical videos and dive into the real world journey between the cornea and the refractive training and the choices that we need to make and the challenges that we face, the learning curve that we have. So we are very privileged to our chairpersons, Dr. Ritu Arora ma'am, Dr. Namrata Sharma ma'am, our co-chairperson, Dr. Sujata Das ma'am, and our conveners, Dr. Anujit Paul, Dr. Rolika Bansal, and Dr. Prasanna V. Ramesh. And I am very happy to say that we have an expert panel, mentor panel with us who are going to guide us and give us their insights into the years of experience in the cornea and refractive training and training so many young ophthalmologists themselves. And we have a list of very young, dynamic residents, senior residents, and fellows who are there with us as the mentees. So we are going to have an interactive poll session over here, and you can vote in this polls. The mentors can do it too. You can also share your questions in the chat box so that we can make it a more open and engaging discussion. So with this, I'm the program coordinator, and with me, I have Dr. Lippy Mittal, who is the co-moderator with me in this session. We are very thankful for our organizing team and our UC Governing Council for giving us this opportunity. So with this, I wanted to invite Dr. Namrata Sharma ma'am, who is the current professor of ophthalmology at AIMS New Delhi. She is also the treasurer of Asia Pacific Academy of Ophthalmology and also the chairperson scientific committee, All India Ophthalmology Society. She has numerous book chapters and numerous publications. I also wanted to invite Dr. Ritu Arora ma'am as the chairperson. She is currently the head of Department of Refractive and Cornea Surgery in Shroff Eye Hospital, New Delhi, and she was the director of Guru Nanak Eye Center from year 2020 to 21. She has got the Professor of Excellence in year 2022 till date. And she was also the Dean of Maulana Azad Medical College, New Delhi from February 2021 to 2022. I welcome Dr. Sujata Das ma'am as our co-chair. She is currently the consultant cornea and anterior segment and the medical director for Drishtidan Eye Bank LBPI Bank Network, Eye Bank Network, and she is also the vice president for the Eye Bank Association of India. She had done tremendous jobs in the Eye Bank standards for India in 2020 with the NPCB and the Government of India, and has done tremendous good work for the COVID-19 practice guidelines for the eye cornea and eye banking for All India Ophthalmological Society. I welcome our convener, Dr. Prasanna V. Ramesh, who is currently the Joint Secretary for UC. He is also the editor-in-chief for Oculus Gus Resto, where he gave a lot of young ophthalmologists a good chance to write a book chapter. He is also the editor-in-chief for Tamil Nadu Journal of Ophthalmic Sciences and also the research director and glaucoma head at Mahatma Eye Hospital, Trichy, India. I welcome Dr. Anujit Paul. He is currently the consultant and cataract and vitreoretinal services at BBI Foundations, Kolkata. He is the assistant professor at Ramakrishna Mission Seva Pratishthan, BIMS, Kolkata, and also the visiting consultant at B.R. Singh Railway Hospital and M.N. Chatterjee Memorial Eye Hospital. He is also the Executive Committee member at Ophthalmological Society of West Bengal and Kolkata Associations of Ophthalmologists. And I welcome Dr. Rolika Bansir, who is an ocular oncologist and oculoplastic surgeon at Mahatma Medical College in Jaipur, Rajasthan. She has numerous publications to her name. She is also an executive member of OPI and executive member for Yosi and has won several awards, including the APAO Achievement Award. So with this, I hand over my podium to my co-moderator, Dr. Lippy, to introduce our mentors, please.
Thank you, Dr. Sanandini. And it is my huge privilege to introduce our respected mentors for today's session. Dr. Uma Sridhar ma'am, she is a senior consultant, cornea and cataract at Eye Care Eye Hospital and Postgraduate Institute, Noida. She is the former president of Noida Ophthalmic Society and former editor, Noida Journal of Ophthalmology. And she is also the DNP coordinator and in charge at Eye Care Hospital. We welcome you, ma'am. Our next mentor is Dr. Himanshu Matalia, sir. Sir is the leading cornea refractive surgeon at Narayan Netralaya, and sir is also the past president of Cornea Society of India. Our next mentor is Dr. Samrat Chatterjee, sir. He is the senior ophthalmologist at Cornea Anterior Segment Services at MGMI Institute. We welcome you, sir. Our next mentor is Dr. Gautam Singh Parmar, sir. He is currently the consultant and head cornea and refractive surgery services at Sadguru Netra Chikitsalaya Chitrakoot. And sir has multiple awards like Young Achiever Award by ISCRIS. He is also the section editor of Cornea, AIOS Time, and Bulletin of All India Ophthalmic Society. We welcome you, sir. Our next mentor is Dr. Prafulla Maharana, sir. He is the additional professor at RPC AIMS New Delhi. He is also the secretary Delhi Ophthalmic Society and editor DOS Times. He has multiple publications, numerous chapters in various national and international books. We welcome you, sir. Our next mentor is Dr. John Sarkar, sir. He is the associate professor at IIMI SR BCRH Haldia, and he is also a visiting consultant at multiple hospitals, Trinetralaya, Fortis, Pushpanjali, Alokika, and BEC. Our next mentor is Dr. Karan Bhatia, sir. Sir is a senior consultant at Manaktala Eye and Maternity Hospital. He is a consultant at Drishti Eye Foundation, Meerut, visiting cornea consultant at Swanjyoti Eye Hospital, Lucknow, and Sri Sai Netralaya, Gorakhpur. He is also a vice president of Yosi and ambassador of Eye Foundation of America. Sir has multiple awards to his name and many academic achievements. He has also developed the MYX technique of SFIOL implantation. Our next mentor is Dr. Gunjan Verma Shah, ma'am. She is currently working as consultant at Gunjan Eye Hospital, Ahmedabad, and she has presented various papers and posters at state level and national level conferences. Our next mentor is Dr. Rajshekhar Paul, sir. Sir is currently working at Shankara Netralaya, Kolkata as an associate consultant at Cataract and Cornea Services. So we have a keynote speaker today for Dr. Tushar Grover, sir. He's a medical director at Vision Eye Center and visiting consultant at Sir Gangaram Hospital. Sir is also a reviewer of journals such as IGO and AGO, section editor, refractive surgery at DOS Times, and coordinator for ISCRIS Delhi and section editor at DOS Times. So with this, I introduce our program coordinator for today and moderator, Dr. Sunandini Bose. She is the HOD of Department of Ophthalmology, Bhagat Hospitals. She is an executive member of Yosi and team lead of Yosi Career Portal and co-team member of Yosi Socio-Cultural and Cornea Focus Group. And myself, Dr. Lippy Mittal, and I am currently working at Center for Sight as cataract and refractive surgeon, Palwal. So with this, I request our Vice President and Joint Secretary, Dr. Karan Bhatia sir and Dr. Prasanna sir, to address and say a few words.
So thank you, Sunandini and Lipi, for the great introductions. Let's say good evening, everyone. Happy Lori, happy Pongal, and a warm welcome to the Cornea Tech Unplugged. On behalf of the Governing Council, executive members, and PWG groups, I'm delighted that all of you could join here for this interactive webinar, which focuses on cornea and refractive training, where learning goes beyond theory and into real world experiences. I would like to extend my sincere thanks to our chairpersons, our co-chairperson, our mentors for being with us today and for generously taking out their time to share their experiences and insights. A special word of appreciation to Rolika and Anujit for the brilliant idea behind the concept of this webinar series, to Dr. Prasanna and Dr. Sunandini and Lippi for executing it so effectively and shaping it into a promising webinar series. Thank you all to the participants, all the mentees for being here. This is for all of you. And I encourage everyone to actively engage in the polls and discussions. Thank you to JB Pharma for being our support from the trade side. And once again, welcome you all to Cornea Tech Unplugged. And I wish you all a great learning session. Thank you.
Thank you, Lippy. Thank you, Sunandani. Hope I'm audible.
Yes, yes, you are.
I'm traveling a bit. Yeah. Thank you. And this idea actually stemmed up during YosiCon, a simple mentor-mentee concept, how it can go a long way, in getting the next gen groomed. So this is the reason why
I think Prasanna has lost his internet. Anujit, can we have your views?
mentors, mentees
Yeah,
for being here, and looking forward to a vibrant evening of Cornea Tech Unplugged after a glaucoma session, which we had last month. Over to you, Sunandani.
thank you so much, Prasanna. Dr. Anujit, if you would like to say a few words, please.
No, thank you so much, Sunandini, for putting all the hard work. I just want to put that on record that Dr. Sunandini has put a lot of effort for today. Especially, we need to put more effort in webinars where you do not have didactic talks. That is why we have a lot of people on the back end to manage the huge crowd that we have today. And we've put up a lot of interesting questions. These are the questions which are burning on our mentees' minds. And I hope that today serves as an interesting but also an insightful webinar so that we can get a lot of questions answered, not only for now, but also for the next half decade or decade coming across, especially in cornea.
Thank you so much, Anujit. Dr. Rolika, your
I think a
thoughts
lot
on
has been said, and I think I would just add one thing. I thank the governing council for making sure that they accept all the ideas that come in their way. I think that's a very strong foundation that they have put up for Yosi to be able to do whatever we would like to do, and that is an important yes that they always have. I think Dr. Divakant always has a is a yes man when you ask him a question and he's like, yes, go ahead, and so is Dr. Karan Bhatia. So I think it's a very important factor that plays a role in having us all organize these webinars. And the only purpose of having the mentor mentee session, as I stated earlier, was that we would like the mentees to be able to ask and communicate with the mentors that they look up to and they wish that they could go up and ask questions to. I remember when I was younger and I wanted to ask some questions at a conference directly to one of the the big names, and I would be like, I'm scared of asking those questions, can I actually go and ask? So this is the reason why Anujit, me and Prasanna thought that we can actually bring this together so that you all can ask your questions. And just to put it on record, we have a very interesting series coming even after this, and Dr. Lippy is helping me with that. And we will be putting up an entire series of every subspecialty where you can ask any of the questions as well. We will be kind of continuing the mentor mentee segment in a way. So over to you, Sanandini and Lippy. All the best for the session.
thank you. Maybe if you would like to take our chairperson and co-chair's comments on mentorship, please.
Yes, Dr. Sujata ma'am is here. Ma'am, your comments.
Good evening. I think this is my first experience with Yosi. I've never attended anything in Yosi. But the program itself looks very exciting. I look forward to this. I know the WOS has a mentor mentee program, which is supposed to be throughout the year. But I'm not sure whether Yosi has this is per year or this is just one session. But whatever it is, but this is very interesting and interactive. Look forward to this exciting meeting.
Dr. Ritu, ma'am.
Yeah. Thank you for having me here. And I'm very excited and I feel very young when I interact with all you youngsters. It's really a pleasure to interact with you. And I think there's far more for me to learn than I can really give it back. So let's have an interactive session and see how it goes. Thank you very much.
Thank you, ma'am.
Mhm.
Thank you so much, ma'am.
Mm.
I think Namrata ma'am is not here
Ah,
till now.
yeah.
So we can just go to the poll questions, the first poll questions, if everybody is okay with it. So the concept is mentees that you have to click on the poll that is going to come on your chat box, and then we can take the discussions according to the flow. And the mentors can do it too. So I'm just sharing my screen again. Just a minute. Yes. Yeah. So Lippy, you just wanted to, I wanted to you to just tell the
Yes.
mentee's
So
name once, please.
we have a very enthusiastic mentee panel today. Dr. Ayush Sharma, Dr. Ajay Sayal, Dr. Apurva Mehta, Dr. Ayushi Bansal, Dr. Kanchan Sharma, Dr. Mehak Gupta, Dr. Nikita Srivastav, Dr. Prachi Khandelwal, Dr. Ramneek, Dr. Ranu Sharma, Dr. Renu, Dr. Rituparna, Dr. Shrey Raj Singh, Dr. Shrideep, Dr. Shubhashish Dev, Dr. Tanya Roy, and Dr. Pragya Gupta. They all are postgraduates, SRs, fellows, and with keen interest in cornea. So today they are going to ask and interact with our mentors directly. So with this, we can have our first poll, ma'am.
Okay. Are you ready, mentees? Okay. So this, I think some internet issues there. Yeah. So this is our first poll question. Were you trained to do a corneal suturing in your residency? So you have to answer the poll. Mr. Sai, Mr. Manjula, if you can have the poll on the chat boxes.
Yes, doctor.
So can we have the poll result, Manjula?
1 second, doctor.
Okay, so nobody has answered. I think that they don't want to answer it. Okay, so
No,
they
they're
had
It
they're
still
just
still
came
answering.
now. It just came
okay.
now.
Yeah. So they are still answering. So 50% of them have answered that they have got to do corneal suturing. So 56% of the people are saying that they got to do corneal suturing in residency, and 47% of the people are saying that they could not do any corneal suturing. So then we can take the next question there. Do you think the residents need to be trained to do corneal suturing? So this question is directed to our chairperson, Dr. Ritu Arora ma'am, Dr. Uma ma'am, Dr. Sujata Das ma'am, please, if you can enlighten
Yeah,
us. What is
I feel we should do, although there are a lot of sutureless surgery. Nowadays, people, all the residents do not learn ECC. But I think when there is a complex situation where you need to convert, or even if you may not be a cornea surgeon, but corneal tear, small corneal tear, you may not refer to somebody. And suturing practice, there are a lot of weight lab. You can always do weight lab practice. People do in the sponge or in cornea. If you have access to eye bank, rejected corneal tissue, our residents and fellows, they used to do that. PK suturing also, they do in the weight lab. Although we'll change to DSEC, DMEC, but TPK in Indian context will not go away. And we also know optical keratoplasty will be there. It will not cross, endothelial keratoplasty will not cross 50%. Even dark, you need to do suturing. And suturing is not just easy thing. You need to maintain radiality, you need to do watertight closure, all those situations. So it's definitely there. You may not do ECC, but still there are institute where they train people at least 10 to 15 ECC. But in this, again, same thing in our institute also, hardly ECC people did learn SICs. But I think we should make sure at least some suturing they should do, so that when once they convert, they'll be able to do a good job, even if they convert, or even the small corneal tear comes also. It complex corneal tear, you may need to, corneoscleral tear, you may need to sometime refer, but the patient may not go. So I think basic cornea suturing techniques should be taught in the first year or second year.
Thank you, ma'am. Ritu ma'am, your
Yeah,
comments.
I definitely agree with Dr. Sujata. And I know it's nice that now we have gone to sutureless era, but as we are progressing, I don't think we should forget the things of the past. I mean, I still don't consider things of the past because I don't know what happens in our other hospitals, but we used to make a resident start with an extra capsular, maybe 8 to 10 extra capsulas, and then go on to SICS, and then go on to phacoemulsification. I don't know what's the practice in other medical colleges, because at times you might have to convert, or you might be in a situation where you need to give a suture. And so it is the most important thing. And it's a skill which everybody who's doing cornea should definitely be trained in. You may have a perforating wound anytime. And I mean, I know that the other day I had done one penetrating cataplasty maybe 3 or 4 months back. And I was at Keracon, and that's where one of my residents just called, maybe a junior consultant called, saying that patient had had a trauma and had a wound dehiscence of the corneal graft. So there was a traumatic wound dehiscence. So they were all very nervous at that time, since I was at Keracon, that I couldn't go for resuturing or anything, that how would they go back and put the corneal sutures. So you never know in what state you would be in. So this definitely you have to learn the basic principles of corneal suture, and perforating injury will always be there. Yeah.
Thank you so much, ma'am. I completely agree with you that, but what happens that a few medical colleges, they have emergency duties. So because of these emergency duties, they get to do all these corneal suturings or lid suturings. But definitely in some medical colleges, this is not being done on routine basis. So maybe that is why the 50% of the people, they had no experience or doing the suturings. But I really think that there should be some wet lab trainings at least to do the corneal suturings. Uma ma'am, your take on this question, ma'am.
I completely agree with Dr. Sujata and Dr. Ritu. Actually, I mean, every postgraduate student, I see two of my, one current and one ex-postgraduate among the mentees. I think it is something like that, like Sujata said, if you have a sponge, you can do on that, the suturing material that is there. If you get, if you get eye bank corneas or even goat's corneas, you can just do the suturing. It is a must that you should know. Even if you're doing phaco, suppose you have a side port leak or a main wound leak, you would know how to put sutures. So when we do the phaco training, we find the students and the phaco trainees are very good at doing the phaco. But then if they had to put one suture, they'll take 10 minutes for phaco and 20 minutes to put that one suture. So, this is something I think people should know, whether they know ECC or not. Of course, you need to know how to bail out. And nowadays, in the era of clear corneal phacos, you should know how to bail out with an ECC, or even in an SICS for a large wound, you might need to suture, and tear repairs will come anytime. As a general ophthalmologist, also, you should know how to do a tear repair. So there is no excuse. As a SR, as a PG, in your night duties, anytime, suturing is a must. It's no excuse at all. So I think I am from the era where we used to do 80 silk with our hands, and when our professors were doing it with the forceps, we used to think it's something very great, no touch technique, etc. But with the finer sutures 10-0, 11-0, I think once you practice, you can do the reverse suturing, any kind of suturing, and purse string, etc. But training is a must. There is no excuse. And I'm sure, when you can get the spare sutures and everything in a in a medical college or any training institute, and practice. Just watch, practice, and nowadays not like our times where we used to get the VCR and see the videos. Here, everything is on YouTube. I think it is there online. We never had the benefit of that. We used to go to LVP, get cassettes, then get CDs and DVDs. But now it's on the tap. Since it is online, everything is online. There is no excuse that you don't know suturing. It is a must.
Thank you so much, ma'am. So I think with this question, we go on to our next question. So was there any wet lab available for suture practice in your institute? And did you attend any wet lab practice in conferences and do you think it helped you? So, Manjula, can we have the poll in the chat box, please?
Okay, doctor.
It's so fun to watch the poll because it is so dynamic. Sometimes the yes is more, sometimes the no is more. Okay, so we have come to a conclusion that yes, 35% only people have wet lab practices in their institutes, and 65% of the people say that they never had any wet lab practices. So with this, we move on to the next discussion with our mentors, Dr. Himanshu sir, Dr. Samrat sir, Dr. Gautam sir, Dr. Prafulla sir. Sir, if you can have your comments, please. Himanshu sir.
Yeah. So what exactly is your question?
So that was any wet lab was available for suture practice in the institute, or how do you think that practicing the suturing in the wet lab areas in conferences help them?
Sure.
Or
So, yeah, thank you, Sunandini. See, basically, during my post-graduation, no, there wasn't any wet lab available for me. Dry lab outside in OT with my seniors, and as the previous panelist said, that we did suturing, and then it had to be directly on the patient under supervised live surgery. Having said that, it's always better to have a feel of that particular thing under microscope and in wet lab, and it's absolutely great to do wet lab sessions in whichever way, whether it's conferences or wherever you are able to get wet lab. But the ultimate thing would be wet lab training followed by a supervised live surgery. Remember, there are two different things which we learn here. Wet lab trains your hands, whereas your supervised live surgery trains your judgment. I mean, when you do live surgery, it's the judgment on the go that what exactly you need to do there, and that can only come when we do the live surgery. So yes, we must have wet lab training if whenever possible and whenever chance is that, but make sure we also have hand holding in supervised live surgeries.
thank you so much, sir. I agree to this point that wet labs practice and then you have a live surgery, monitored live surgery really helps you to get that real feeling out of it. Dr. Gautam sir, your opinion about this wet lab services, because we know that SNC has a lot of wet lab
SNC.
areas and
Yes, SNC having a very good wet lab. Mostly
sir,
they
you're
are
not
using
very clearly audible, sir.
Okay, is it okay now? Am I
Yes, sir.
audible now?
Yes, sir. Yes, sir.
Okay,
You're audible.
so as Sunandani said, we have very good wet lab at SNC and made by company people, mostly by Alcon. And we mostly use for the FACO training and SICS training, but we also utilize for suture practice as well as our cornea procedures also. So definitely, I always recommend that if you have a wet lab facility, then definitely it is very useful, especially not only for suturing only, but for other lamellar procedures also it is possible. So definitely, but like wet lab tissue, we know that the tissue is always, I think, too much edematous, and you may not have that feel, but you definitely have some hand-eye coordination. I just want to highlight here also, like I always tell to my fellow that you should learn lamellar surgeries while doing penetrating procedures. Means like if you are doing a optical penetrating keratoplasty for a small scars or for a huge edematous thick corneas with rough stromas, so you always try to dissect it lamella by lamella, so that you can have a feeling of stroma, how the stromal lamellae reacts, how what are the feeling of those, and how can you dissect, and how you should reach up to a depth of the pre-desmatic or desmatic level. So I always tell them, because you are having real time tissue feeling at that time instead of the lab tissue, where tissue may not be that much good. But definitely for suturing, I recommend what you need is just a microscope, even a microscope and a set of instrument like your needle holder as well as two suture time sets. So you can even can do in your OPD also, where you have a small examination microscope. So I always recommend, and it is very helpful for initial for the beginner surgeon. In
Thank
my
you so much,
residency,
sir.
I didn't go through that, but as soon as I joined my fellowship, initially at 2008, it is a rule in agency that we should perform initiate our cataract surgery with the ECC only, and we should put 5 sutures at least to our main wound. So that's why how we trained about suturing.
Thank you so much, sir. I think a lot of us in residency, we learn to do all this rexes and suture practice in tomatoes and uh, uh, potatoes. So this is one very common thing that we have learned through the residency. But with the advent of, I think, wet lab nowadays, it has become much more better, much more scientific to do it. Samrat sir, your opinions about this question, please.
I think most of the this thing what you call mentors have covered nearly everything. I just would like to make to a couple of points. One is that putting a suture in a ECC wound, a SICS wound, and a pure corneal wound. These are three different techniques. So I do not know in the first poll whether by saying corneal they all meant that they had done it on the cornea, or was it SICS, because these three wounds are completely different. So that should be in their mind, that the three tissues or the tissue interfaces that they are trying to join are different. And underneath them also there are different things. So underneath the cornea is pure aqueous. In an SICS, it's a different, and in ECC, which mostly is not practiced nowadays by the younger people. So that they should distinguish these kind of differentiation. And the other thing which is important is that even in the wet lab, at least a senior resident or senior consultant should go and show how to hold the sutures, how long they should make the loop, where they should make the loop, and how they should hold the instrument, where they should place their hands. So sometimes in live surgery, while you're doing it on a patient, these things may not be possible, because if it's being done under local, then the patient is of course awake and you cannot direct everything. So wet lab is very, very important. Now the problem is that it needs a resource, it needs a spare microscope. So again, if you just put in a old bad microscope in the wet lab with faulty optics, it really doesn't help. So a conscious investment has to be made, that even in wet lab, the set of instruments that are there, the needle holder, the tying forceps, they should not be the rejected ones from the OT. They should be a brand new set from a reputable company. So the management or the department must have provision for all these things before starting this thing. What we call providing the infrastructure is important from the department point of view. And it is imperative that anyone who gets an MS, DO, or DNB in ophthalmology should be at least able to put a decent suture.
Thank you so much, sir, for your insight. I think Namrata ma'am has also joined us. Ma'am,
Yeah.
Namrata ma'am.
Yes.
Good evening, ma'am.
Good evening. Yeah,
If you
good
could
evening.
share your views, ma'am, on this wet lab training for the residents and not only the SRs, ma'am, for the future residency or future fellowship programs.
So I think in wet labs have become a norm nowadays, whether for postgraduates or for fellows. In RP Center, we have a dedicated wet lab, and that was, if I can remember, started by Dr. V.K. Dada wet lab almost 30 years ago. At that time, it was very rudimentary, but phacoemulsification, the procedure which had come, it helped not only RP Center people, but all over Delhi to practice that. But I think, yes, wet lab for postgraduates is a must before they actually start to do on human eyes. For us, I don't remember doing a wet lab. We directly went on to do on the patients. In Moorfields, when I went as a fellow there in Cornea, you were not allowed to do any case unless you had already done 20 DSEC procedures in a wet lab and actually maintained a logbook and shown to them that you have done it. And you had to click pictures because there were no videos at that time. So click pictures of what you have done. So I think wet lab gives you a different kind of a confidence. And one more thing I always feel is that it is easier to do cases on human eyes or in real situation rather than on wet lab. Because although we do say that the wet lab area should not have instruments which are not used earlier or should have brand new instruments or brand new machines, but that doesn't happen. We'll end up using, machines which we've discarded from the ORs, or land up using instruments, cannulas, etc., which we are not using in the real situation. That's why if you can do anything in wet lab, I think you can do always much better otherwise also.
Thank you so much, ma'am. Thank you for your insights. With this, I hand over the podium to Dr. Lippy for our third poll question. Dr. Lippy, are you there?
Yes. Right. So we move on to our next question. The question is, how many cases of SICS, FACO, ECC do you think should do before you start doing a therapeutic penetrating keratoplasty? 20, 20 to 50, 100, or more than 100? Manjula ji, can we have the poll, please? The majority is going towards 20 to 50.
I'm not sure how many mentees have actually done so many SICs of FACO. I think this is their assumption that we are seeing. So I think we can hear it from the mentors, Dr. Lippy.
Yes, so I would like to ask our mentors, Dr. Karan sir, Dr. John sir, Dr. Raj Shekhar Paul sir, and Dr. Gunjan ma'am. Sir, do you think cataract surgery number is important? And do you think, is there any particular number you should do before doing cornea surgeries, or particularly therapeutic and penetrating keratoplasty? Dr. Karan sir?
So I'll start this off with an example. So in my residency, I had not done a single case of penetrating keratoplasty. So this is DO, about 8-9 months of comprehensive opthal fellowship, and then comes to DNB also. So no keratoplasty is done. So I joined in my fellowship first day at Joshi Eye Institute, and the first day I did about 50-60 cataract surgeries and SICS there. But in the evening, my senior took me to observe about 2 cases of therapeutic PK. So in the last case, she asked me to do you want to suture, ma'am? Sure, ma'am. So she gave me about 3 to 4 sutures, which I finished in 2 minutes. So this is day one. The next day, the consultant calls me to her OPD, and she says ki there's one case of TPK. It require it matlab, perforated corneal ulcer requires a TPK, a large graft, about more than 11 graft. And she said, "Will you be able to do it?" Yes, ma'am. So have you done ever done a PK? I said, "No, ma'am." My senior was there next to me. She's just about to finish her fellowship. She said, "Ma'am, ye kar lega." And I finished the case in about 40-50 minutes and I came up. So what my point of this is, the thing is that I had done more than 2,500 SICS before my first therapeutic PK. So the point is, I always believe SICS is, or ECC, is the backbone of any surgery that you do in the eye. It gives you how to do tissue handling. So I am from the days of ECC also, where we had to do 150 to 200 ECCs before we graduated to SICS. So suturing also you learn. These are very important, and therefore you need to get, basically the idea is that your hand-eye coordination should be good. You should understand the tissue feel and how the eye behaves. And that is where SICS and ECC come in the picture. So I would say it should be more than 100.
Okay, all right, sir. Thank you, sir. Thank you for sharing your insights. Namrata ma'am, your opinion on this?
Completely agree with Karan. I think it should be more than 100 because penetrating keratoplasty, therapeutic penetrating keratoplasty for that matter. And I would again say this in our scenario, the thing is that the juniors do therapeutic penetrating keratoplasty and the seniors do optical penetrating keratoplasty. When I went to Moorfields, I thought there were two cases. One was DSEC and other was therapeutic penetrating keratoplasty. I thought I'm going to be doing it just like we do here. So I sat on the side where the surgeon sits. And then Dr. John Dart tells me, no, this is a very difficult case. You won't be able to do it. You sit this side and I'm going to do it. You will assist me. I mean, I didn't have the heart to tell him that I've done several of these because that is how we begin. So I think doing therapeutic keratoplasty is more difficult than optical penetrating keratoplasty because you're operating in inflamed eyes, hot eyes. Whereas penetrating keratoplasty, optical, you are doing in cold eyes. So it's a lot better. And that is why I feel you need to do at least 100, if not more than 100.
Thank you,
I would
ma'am.
completely agree with Dr. Namrata. We try to push off therapeutics, but that is much more challenging than opticals. And most of us, we should presume, would be average surgeons, not exceptional ones who can, like what we just heard. So we should be, our approach should be conservative. We should start off, with SICS is a different thing, but that would give you hand-eye coordination. But at least one should do 20, at least 20 to 30 wet lab suturings to do all those therapeutics. To put 24 sutures in a large graft when the interface is cornea and sclera with a 10-0 needle, which can bend any time that your direction is slightly off, can be very difficult. So therapeutic penetrating keratoplasty should not be taken lightly.
Samrat, do you remember in LVP as fellows, we were together? They wouldn't give us a therapeutic until you did 20 proper in the wet lab, 20 keratoplasties in the wet lab. So, and then the reverse sutures and all were not easy. We had to use whole globes, sit day and night or whatever night time we got, show the suture, show properly buried radial, 16 sutures or 24 sutures, whatever. And we had to practice keratoplasty before we touched a therapeutic. So it's not just doing an ECC or an SICS. You should also know how to do a keratoplasty in the wet lab. So I disagree with the fact that just doing 50 or 100 SICS and ECC will suffice. You have to do keratoplasties in the wet lab with reverse suturing and everything, because that tissue is loose there. Till you put the first 4 sutures, the tissue can float anywhere. So you have to practice that in the wet lab before you have the confidence to take over. And you need both your hands when you're cutting on the right side, left side, using right-left scissors or whatever. So it's not enough just to do 50 or 100 ECC SICs. You have to do keratoplasties in the wet lab to actually do a keratoplasty. So there I would differ.
I agree with you, Dr. Oma, completely. I think doing number of SICS and phaco has no bearing whether you can do a therapeutic keratoplasty. You are doing SICS, phaco is just giving you a hands-on, that how you can feel the tissue. But doing a therapeutic penetrating is very challenging, inflamed, large grafts. Sometimes you don't even know how to pass a suture. And I remember my first few therapeutic, I had to pass 80 suture. I mean, that's 35 years back. And it's very, very difficult. And more, I think, which has to be stressed to assist a senior in therapeutic or a proper keratoplasty, because you learn far more assisting than actually doing it. And then you really learn that how your senior has actually done the surgery, how the exudate has been removed from the pupil. Even doing a simple iridotomy or iridectomy is very difficult in an inflamed eye. It may be bleeding at that time. So assist at least 8 to 10, and then you get your hands on the wet lab, and then the main surgery.
Yeah, and in the first couple of cases, have someone sit by. And there are a lot of things in therapeutic penetrating keratoplasty which is completely different. So I remember I had some this thing what called exposure meeting, some of our Indian classical musicians, and they would say that just to give 1 hour performance on the stage, they would practice for hours at home, the riyaz. So the
Absolutely.
riyaz, so why would they do the riyaz? Because they're already like, Bhimsen Joshi every morning, like I have seen him do riyaz in the morning and then perform. The riyaz is the same thing that we do in the wet lab or we do in the in our mind, like in the wet lab or the suture practices that you can come and do. So I don't think even if you do 1,000 uh, phaco and I put you on this thing, unless you are exceptionally gifted, you'll be able to pass 4 cardinal sutures in a graft.
Absolutely,
Sometimes
I
a
think.
very well done therapeutic also works like an optical PK.
Yes,
So
yes,
don't
yes.
really underestimate the power of therapeutic, where we will normally say it's a guarded visual prognosis. Your aim is to give vision to the patient. It's not only that you are doing a tectonic purpose. So a
Yeah.
well done therapeutic can also work very well.
Yeah, you'd rather avoid
Absolutely,
the
ma'am.
second surgery.
Yeah.
You'd rather avoid a
Absolutely.
second surgery. You'd rather
Yeah,
avoid a
and
second
John,
surgery.
you are
forming a
not
chamber,
audible.
Or,
forming a
yeah,
chamber in a keratoplasty is not easy. The first
absolutely not.
one, so there comes the role of suturing, and more so difficult in a case of a therapeutic. So all these things have to be learned, practiced till you actually go on to doing things.
True, ma'am. Watch, observe. That's why like when we have the logbooks, it says OASI, observed, assisted, supervised, independent. So it
Yeah.
goes stepwise like that.
So residents who are thinking that if you do 1,000 SICS fake or say ECC probably would give you a lot of experience, but you are not doing ECC. So you're thinking you'll do 1,000 SICS FACO and then jump on and do a therapeutic, unless you are God gifted, you're not
Even
going
a
to be
God
able to
gifted
push.
person, I think it's difficult.
No, no, yeah, it is.
Dr.
All our first,
Yeah.
all our
Yeah,
first
because I
project,
remember our initial time.
yeah,
E-
all our
Yeah,
first
Namaste.
project,
No, not initial
Everyone
time,
has to
Dr.
practice
Ritu.
in the wet lab, no matter what.
yeah,
Even if I sit in a therapeutic right now, even if the graft is not, if the graft is not, if I don't even have to take a large graft, maybe 9, 8.5, 9, I'm still not 100% confident that I would be able to form the AC and have a good outcome in 1 hour's time. In
Yeah.
optical penetrating keratoplasty, I'm much more this thing what you call predictable, but with therapeutics, I'm not. So I think this question should not be there. If
And also whether
I have to
you're
be very
giving a
honest,
block or you're getting a general anesthesia.
it
I
makes a
I
must
lot
prefer
of
general
difference.
anesthesia.
Makes a
Yeah,
lot of difference.
it makes a lot of difference.
Oh, I
Yeah,
would prefer a GA anytime, but for perforated
That
yeah,
ulcer.
doesn't happen.
Yeah, that's what I'm saying. So it's the story starts from there.
yeah, and mannitol. So, Dr. Sunandani, this question is redundant, at least from my point of view.
I agree with you, Samrat, for once.
We also have Dr. Raj, Dr. Gunjan, and Dr. John, sir. They wanted to say something. If you can please, Dr. John, sir. Sir, we cannot hear you. Dr. John.
Dr. Rajshekar sir is here.
Yeah, what I wanted to say that in our place at Sankaleshwar, right, we are giving students after they have completed their wet lab, we are giving them some steps like we allow them to give some of the features at the end in the therapeutics because of the less optical prognosis. But yes, at the same time, cataract as it has been said, and I guess I'm the most junior most mentee over here. As it has been said that Madam said that cataract surgery has no bearing over the therapeutic penetrating keratoplasty. I completely agree with that. So they need to do wet labs, then some supervised sutures they show us. Then only we allow them to graduate from 4 sutures, 8 sutures, and at a very later stage only we allow our juniors, our fellows, at least after a year or so, to give, hand a complete surgery.
No, sorry, I'm
Yes.
butting in again. And but I apologize for that. But I want to know, why do you want to give residents, that is someone who's doing a DO, MS, or DNB in ophthalmology, a therapeutic penetrating keratoplasty or suturing for that?
Uh,
For at this stage, probably medical cornea is much more important to them, and probably some training in doing basic corneal tear repairs rather than doing penetrating keratoplasty. So suppose we go to the VR, would the VR person say that in residency, okay, can they stain the ERM and I'll peel it off, or can they do, ERM peeling? I think the therapeutic penetrating keratoplasty is something like that. So in residency, medical cornea probably would be should be more in focus rather than putting in doing a therapeutic penetrating keratoplasty or DALC or DSEC.
uh, Sorry, sir, I was talking about cornea fellows actually, from resident I mean, but fellows in the training in cornea.
Yeah, fellows, of course. But I'm talking about for these
Dr.
three
John,
categories.
Dr.
Yes,
John,
sir.
sir, your comments, please. So you're not at all audible. No, sir, you're not audible. Dr. Gunjan,
Dr. Gunjan
your
ma'am is here.
Hello. I would like to add that ECC around like once we have done 60 to 80 ECC and SICS, then we will be able to handle the endothelium, AC formation, IUL implantation, and overall our tissue handling will improve. And yes, before doing therapeutic penetrating keratoplasty, wet lab is very much essential because we have to take sutures at 4 o'clock, 7 o'clock, and they are very much different than the ECC. So I agree that wet lab for TPK is very much important.
Okay,
And,
ma'am.
and before that, I also want to say the decision whether one has to go for therapeutic or not. I've seen number of times the decision for therapeutic is done, but there may be somebody else who just pursues with conservative and the ulcer heals.
Yes,
Because
yes.
that also happens. So it starts from there.
BCL and yes, they can help.
Dr. John.
Dr. Rao used to say, when he would berate us, Dr. G.N. Rao, that he could make a cobbler do a PK, but he wouldn't be able to make the cobbler decide on doing a PK. So I completely agree with Dr. Ritu that decision making is important. With therapeutic, either you delay too much or you intervene too early. So the timing is very crucial for any surgery for that matter.
Dr. John, you are. No, you're not audible, sir.
I think we can move on to the next question.
Yes, we can.
Okay.
For the interest of time, we can take sir's opinion on the next one also.
So our next question is, was there adequate exposure to lamellar keratoplasty in your institute as a fellow? And the part 2 of the question is, if not, this is pertaining to the mentors and the chairperson. If not, what to do next? So can we have the poll, please, Manjula ji? So most of them are denying any exposure to lamellar keratoplasty in their institutes as fellow. So my question is to Dr. Himanshu sir, Dr. Sujata ma'am, Dr. Gautam sir, and Dr. Namrata ma'am. What do you think, even if a fellow who is doing a long-term cornea fellowship and they still don't have any adequate exposure to lamellar keratoplasty, what is your take on it, and what to do in such situations? Dr. Dr. Sujata ma'am, yes.
Yeah, I don't know what is the definition for adequate, but I think there should be exposure. It cannot be zero. lamellar keratoplasty somebody does, at least the fellowship is either 2 year or 3 years. There should be some exposure. We cannot say it adequate or not. If they don't have, in case they're finished or they're going to finish from the mentee side, there are enough scopes. Nowadays, the DSEC workshop, many institutes are doing DSEC workshop. Kerakan is doing a lot of workshop also, our wet lab is there for lamellar workshop. The numbers definitely is less in many places because there are not enough surgeon who is doing DMEC. The alcohol number also, maybe the indication is less in India. So DSEC is most commonly performed lamellar procedure. And if somebody has done, like the previous question was definitely not redundant, but this question is, if somebody has done PK, is much easier to learn. The learning curve wise DSEC is easier than DMEC, so they can start is from DSEC, then go to DMEC, and DALC also definitely they can do in white lab. If they have excess tissue in the eye bank, they can do all those white lab. But PK we keep a number definitely. But in our fellows also we don't do them white lab practice for DSEC. PK they have to do 20. So all those they can do, but there should be some. If we are doing cornea fellows, there should be some exposure to this. And they go to meetings. They go to meeting. They can after the fellowship over, they can do a like observership in many places. All those options are there.
One sec,
Sujata.
Sujata, when we were doing fellowship, sorry, Samrat, you, I, Sujata, we didn't have exposure to lamella.
Yes.
When we came out learning only PK.
Only
so
PK,
the lamella
yes.
started later on. So the question was, did you have? We did not have. So what
No,
did
no.
we do?
We did not.
No, Uma, that's a different point of thing. What I meant,
Right.
Sujata,
You would have
why would
done
you
manual
say,
lamellar keratoplasties, wouldn't you? I mean, we all also came out, but we used to do manual lamellar keratoplasties.
Dr.
No.
Namrata, in
No.
2001, there was no lamellar in LBP
No,
also.
Arey, Anita Panda to used to do from times immemorial. If
I know, no,
Dr.
we didn't have that, Dr. Namrata, there.
Acha.
No, we
So
did
y'all
not
were
have.
like, okay, y'all,
Because
no,
even Dr.
see,
Vajpayee, Dr. Anita Panda, we learnt our lamellars from them only. And
no, the question that Sujata made of this thing is that why should, at this current times, if there's a cornea fellowship, a
Yes.
cornea fellow should be exposed to lamellar. If that
Yeah,
program,
because
if
during
if
our
that
time there is
program
not
is
much of
not
lamellar.
giving them an exposure to lamellar, then that program should not run.
Yeah, I'm saying that there should be exposure. It may be adequate, may not be what is the number of adequate, no definition for that.
Yeah,
But
yeah.
if somebody is
Adequacy
doing a
for me would
long
be
term,
probably 100. For someone, it can be 10, right?
yes.
So
But
for an average surgeon
there
to
should
be
be
more,
some exposure.
there
Should be
should be
some
some exposure. And like, because I think Dr. Lippi said, what is the take? The take is that if there's a cornea fellowship program currently in 2024, where the fellows are not getting exposure to lamellar in any form with any number, then that program should be termed either as medical cornea, which it doesn't exist, or probably that shouldn't exist. That program should not be exist.
no, suppose somewhere
26,
there is
Samrat,
only
That
20.
somewhere there's only penetrating keratoplasty and no lamellar keratoplasty. You
I
can't say
think we
that.
should not be so critical
Yeah,
about such kind of
because
thing.
these things you
Cornea
also
is
learn.
not just lamellar keratoplasty only.
Yeah,
So
you pick up these things later on
No, I'm
in
not
your
saying,
life.
see, exposure should be there. There should be some exposure. Like it's like happening the same thing that in medical colleges or in many institutes, you can do your cataract surgery after you get the degree, short-term courses and fellowships. So you do a fellowship in cornea, and then again you land up doing a fellowship in DALC and a fellowship in DSEC. So it adds. The program itself should be strong enough to uh, encompass all these techniques right now. At
Samrat,
least
I
I
totally
think
agree with you
for
that
DSEC, there's hardly, I mean, I don't think there's too much of learning curve for DSEC if you know how to do phaco and if you know how to do
Yeah,
penetrating keratoplasty, given the fact that now you get pre-cut tissues also. For
yeah.
DMEC, there is a learning curve. Again, I don't feel if when you get pre-stripped tissues or, I mean, once you know how to do phaco, once you know how to do penetrating keratoplasty, then doing lamellar learning curve is there, but it's not a big deal. I mean, somebody who's doing a full thickness keratoplasty is a cornea trained person. You can't say that he's medically cornea trained. That is no what I mean to say.
True. I agree with Dr. Namrata, and I guess we understand your logic, Samrat, and भावनाओं को समझते हम, but I don't think we should be so critical that they should close down. They should not call them.
No, there are many
There
places.
are
Yeah, sorry, you continue, then
no,
I'll
please,
speak.
please,
No, no,
please.
no, 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 you continue, Himanshu.
No, I was just telling that there are, in fact, we have such scarcity of cornea surgeon across the country. We want more and more people to teach them corneal transplant. We want more and more people to be mentor for penetrating keratoplasties, and of course, they themselves can slowly start learning lamellar keratoplasties. But so it does not mean that they should not be exposed. Of course, I totally agree with Samrat that we should find out a way to expose them. Now, the adequacy of exposure can be quite debatable. But what, from a fellowship point of view, we should understand that the duration also is very important. You cannot compare a fellowship of 3 years or 2 years versus a fellowship of 1 year, where you want to get everything possible in that short period of time, which may be very difficult. So some of the fellowships are short duration, some of the fellowships are longer duration. So if you end up in a fellowship which is little shorter duration, if you do not have that much hands-on experience of a lamellar keratoplasty, it's not as bad. As Dr. Namrata said, it's not a surgery which is most difficult to perform surgery. Yes, everything can have its own learning curve, and that's what we want to do throughout our life. Once you finish fellowship, in fact, your career is just starting. This is the beginning. It's not the end of it, right? So in those scenarios, we can go for observerships, high volume observership. We can go do focused wet labs in many places which are possible. We can do short-term surgical training, can do wet labs assisted, can ask our senior to help us out in OR. And basically, it's all these things we learn from our exposure to the failures, and that's how we learn. And I think Samarat or Dr. Ritu said that during, or I think somebody else said that during our penetrating keratoplasty, we start doing lamellar keratoplasties, then convert into penetrate. There are many ways of learning, and I'm sure if we decide to learn, we should be able to learn, and it's not as difficult. But lamellar keratoplasty learning is something which is going to be important for any training program, and we should include that.
Thank
That's
you
what
so
I
much,
meant. We
sir.
should include it, some exposure. I'm not saying you make an expert out of it.
Because
Dr.
I
Prafulla,
remember we
sir,
used to
thank you.
have DSEC trainings in RP Center, and we would choose, we would do 3-day workshop, and even with Site Life, we did that. So there were a lot of centers and a lot of people from various centers or government hospitals who were doing penetrating keratoplasty very well, but had no exposure to lamellar keratoplasty. So they would learn from, these workshops, and then they would go back and, do that. So I think penetrating keratoplasty is the most difficult thing to do. If you can learn that, then
I'm actually more scared of now penetrating
full thickness,
keratoplasty
yeah,
than
opening
any
the
of the lamellars. Whenever there's penetrating, I have a sleepless night.
Open globe is always scary, ma'am.
Also here.
Dr.
Yeah,
Namrata's that award-winning video.
Mm.
Dr.
Dr.
Namrata, after
Prafulla,
your
sir, Dr.
award-winning
Gautam,
video
sir,
of
Yeah,
that
your
expulsive.
volcano. Yeah.
Don't remind of that.
Mhm.
Dr. Prafulla sir has also joined. Sir, your take on this question, Dr. Prafulla sir.
Dr. Gautam, sir, also, please.
Okay, so my take on this, that yeah, definitely at Sadhguru we have exposure to our fellows. I don't know whether it is adequate or not, but we definitely having exposure. And if you don't have, means if you feel that it is not adequate, you can learn by your own. Like at Sadhguru, we make them comfortable with the penetrating keratoplasty. So always keep a tissue so that you can convert, if it is happens, if something wrong happens, you can convert them to penetrating, and you can learn by your own. As I said before also, like you can learn lamellar keratoplasty while performing your penetrating procedures. Like you can dissect your anterior lamella while doing optical penetrating keratoplasty. You can dissect lamella lamella by lamella, so that you can have a feeling of your stromal dissection. And you can, even the DALK you can do manual also. You can reach to up to a enough distance by manual dissection also. It is not necessary that you always have a get a big bubble and all. So it is possible. And like similarly, if like endothelial keratoplasty, if I talk about, it is very much similar to SICS. The dissection of the tissue is very much similar to SICS. Like you are just feel that you are making a tunnel, but it just across your whole diameter of the cornea, you are making a deep tunnel. So this is just like that. So you can learn by your own. You can have a CME also. You can call some expert surgeon to your institute, and you can learn. You can get wet labs also. And one more thing I would like to highlight here, that is my perception also, and that is I feel that those fellows from us, we train a lot of fellows. So those fellows, we are having keen interest in editing our videos. They are having very good reflexes while doing surgery. Means keep editing the surgical videos of your seniors, your expert surgeons. So it is always helpful. It is helping in making reflexes and making networks inside your brain कि किस तरीके से आप hold कर रहे हैं instruments को, कैसे आप edges को hold कर रहे हो, how to put sutures. It helps in every steps of your learning. So always try to edit videos carefully of your seniors or expert surgeons. This will also help, because this is I realize at my institute that those fellows who are having good in their video editing, they are good surgeons also. So this might help. So this is take from my side, that these things may help you learn the lamellars. But before going for lamellar, you should be comfortable with penetrating procedures so that you can convert in emergency.
Thank you so
Well,
much, sir, for your.
thank you, Sunandini, for inviting me here. For lamellar keratoplasty, my personal experience, I would say I learned my lamellar procedure by assisting Professor Rasik Bajpai. Sir was here for 1.5 years, and I used to assist him in most of his lamellar procedure. So I think for fellows and residents, it's very important to know how to go step by step. Initially, he used to do dissect and ask me to put sutures only after putting four primary sutures. Then he started giving me putting all the 16 sutures. Then he asked me one day to do a DLK in the case of macular dystrophy, and he was assisting me. So it's very important to assist your mentor. And during assistance only, you have to keep on noting down how you are tying the suture, how somebody is doing lamellar dissection, what to do when your dissection is going deeper, especially when manual dissection. So assisting helps you a lot. And second part, I completely agree. While editing video, a lot of things you miss when assisting or even doing. Once you go back and just start editing, you see these small clips, small mistakes, then you learn. And one more thing I always advise my SR, ki don't try to observe only good surgeons. Always try to observe some bad surgeons also, who are learning and doing some major goof ups, because you will learn what not to do by watching those surgeons. I won't say bad surgeons, but those who are learning, they do mistakes. If you assist them, then you learn these are the things that you should avoid. When you assist experts, you learn, yes, these are the things that one should do. So I think lamellar is all about assisting, learning, and I completely agree with Dr. Himanshu what he said. If somebody can do PKP, he can do lamellar procedure. Only some practical tips which you learn by assisting or attending CMEs, all these webinars. Nowadays, you people have everything, learning programs. So that really helps. So lamellar is not a big deal if you are a good PK surgeon.
One
Thank you.
thing, one
Yes, sir.
point which I want to emphasize what Praful said, and it's so important to assist somebody. And when I said assist, please make sure that you're not sitting there. Many times I've seen that fellows, they are not scrubbed, they come peep inside, then go on phone and something. That's not how you learn the surgery. If you want to learn surgery, go and scrub and sit there throughout that. And trust me, even if surgeon is very quiet, but they end up talking something, some points which they give you pearls, which is not going to be there anywhere in the books or something. And you gather these pearls when you are with them throughout the surgery and not just loitering around looking at the monitor. That's not assisting. Looking at a monitor.
Thank you so much,
Yeah,
sir.
Sunandini, I'll just add one more
Yes, sir.
point.
Yes, sir.
One
Sorry.
thing I missed, always see the post-op. Whichever case you are assisting, see the post-op because that is very critical. Your suturing, what is the graft post junction, interface, everything you should make a habit of watch next day. Don't think that you have assisted the story ends there. And second thing, well, there was a lot of discussion about therapeutic penetrating keratoplasty. So let me play the devil's advocate. See, it's not extremely difficult. You can do it, but you need a lot of practice. That was the point you should carry forward. If you are a fellow, if you are a SR, then assist and practice. Because in one of our wet lab training program, Dr. Samar Prasad, he said me that he initially when he was doing DMEC, he got disappointed, then he stopped doing that. Then he practiced in his own wet lab for 9 months, and now he's probably the one of the best in world in DMEC procedure. So the take home point from that is you have to practice. If you are a good phacosurgeon, your reflexes are perfect, then you can definitely do a therapeutic graft, but you need to practice.
Thank you so much, sir. With this, for the interest of time, we move to the next poll question. Uh, I would like to ask one of our mentees to ask this question to our mentors, Dr. Shrey. Dr. Shrey, are you there? Dr. Shrey, Dr. Shrideep, anybody of you want to ask this question to our mentor? Dr. Apurva, are you there? Okay, so I think they're not
I
there.
think it's
So
like the OT. The surgeon is operating and everybody is looking at the screen or the phone, like Himanshu mentioned.
So let me ask that how many dial DSEC should a fellow SR perform before an individual practice? A 10, B 20, C 30, D more than 50. And how confident are you to do individual lamellar keratoplasties? So can we have the poll, Manjula? So okay, so the poll results have come, and they most of the people they think that they need at least more than 50 to perform an individual practice to do a DALC or a DSEC. We'll start with Dr. John, sir, because he could not speak earlier. Dr. John, sir, if you are there, so you're still not audible.
Sir is mute.
Yes, sir. Yes, sir. Now yes,
Am I
yes,
audible?
yes, sir.
So I just want two things. First, the last one, something issues in my connection.
Yes, sir.
My
It's actually you're logged in into two devices, so maybe there's an echo.
am I audible now?
Yes, sir. Better.
Yeah. So basically, the last one, the ECC, the one the controversy, I missed it. I want to just share one thing. I'm really fortunate enough to did my fellow, I mean PG from the RIO Kolkata. So since the first year, the decorum was followed. That when I was a JR also. We do the couple of cases for ECC still now, at least 30-40 cases, and then the switch over to SICS and you then followed by FECO. So what the first question was the first poll. No, I'm just taking the previous one as I missed this one. So definitely I agree with the Ritu ma'am and Uma ma'am who was telling what the Karan was telling. I'm doing that. I'm just highly appreciate his skills, but the junior should not be take the things that I showed that I mean 100 factors and then I suddenly go and do another TPK, because TPK really is what the Ritu ma'am and the Uma ma'am was telling, something very disorganized and the putting the suture and everything. So it need the couple of cases, and what the Prafullo and the Shamrat sir was telling, we also learning by the assisting the cardinal suture, senior sir put then one or two suture, gradually learn the things. So once you are expert of the technique, the therapeutic and the optical one, that will cause the much more hand-eye coordination, and your skill will be much better. Then now moving to the that your dialectic or whatever the lamellar process we are doing now, definitely that needs of the learning curve is there. And initially, whatever we are observing our seniors doing assisting, as well as we need much more of the more wet lab. What the Praful was telling, what the Shambar Bashak sir is telling, usually during your learning phase, even we completed, there is the exposure should be there. We learn, but number should not be there. It's a relative thing. Maybe your skill is much better than me, so you would need a less number of the cases before doing confidently by your own. But we need much more wet lab session by your, and honestly speaking, during our I mean the fellowship days, we are taking hardly doing or not to I mean dissect or DALK during, but we every weekend we just collect the tissue from the wet lab every Saturday evening, and we ask request, we help to ask the OT people, we stay a little more and just do every time inspired our own. So wet lab session is much more important, and then automatically the number is irrespective. Even also after 10 cases also, if you are confident enough, your skills are very smooth, your reflex are very smooth, you can confidently do the cases. So that's I mean my insight and inputs.
Thank you so much, Dr. John sir. Dr. Ritu ma'am, Dr. Uma ma'am, Dr. Samrat sir, your views about this question.
I don't think numbers per se would matter so much. Sometimes, even after having done 5 to 6 cases, you feel pretty confident. Yes, DALC has a little longer learning curve, but it's just, and it varies from individual to individual, and the surgical sense and passing sutures. So maybe, I mean, I would just look at maybe ballpark figure if you want to give me, even if you do 8 to 10 cases and you get the hang of what you're doing, you are good enough to sail through, you know.
More than 50 is not a realistic number,
Yeah.
actually.
Yeah.
You don't
In a
have so
fellowship,
many
it's not
cases.
possible.
Yeah.
I'm
Then
just
I think 10 should be okay. And then we have option to convert in case, for
exactly.
example, DALK you cannot predict now also. Sometimes it perforates. So we should have a tissue where you can convert to PK. You cannot wait till 15 to do 50 to do individual.
Even after the 50 cases, DAL can be perfect.
Yes, yeah, DAL can perforate.
And and it's really your perception. I'm just simply sharing one of my concept. I attended in I mean our ocular surface, some of the I mean wet lab. I do individual demo, then some of the wet lab session attended. After 4 or 5 cases, I started my own. I mean that paid cases. So it's not like that. It's your perception. It depends on individual how you are previous skilled, and that is the mother skill of this. And always, whenever we should have backup the things that during the learning phase. That's why the always the suturing is important. We should know the mother surgery, that's the penetrating keratoplasty, because if something is going wrong, then even also demic also, if someone don't have spare tissue, then we have always think we can do the demic. But suppose if anyhow there's a perforation or something going wrong, then we have to you had to be confident enough to do the ultrasound dissect or dissect one. So that's it.
If I may
Dr.
come in, I
Samrat,
would
yes,
just say
please.
few things. Uh, See, numbers doesn't matter. That's right. But if your numbers are high, then you learn how to manage complicated cases. That is the thing you
Agree.
learn by more and more
Number.
for surgeries you are doing. But as Sujata ma'am said, 10 cases are good enough. If you are a good observant and if you can do 10 independent cases, then I think there won't be any issue in doing surgeries. But to learn how to manage difficult cases, challenging cases, you need good numbers. Maybe 50 that will say, yes, he's a
I
complete
completely agree
surgeon.
with you, sir, that to learn the complication managements in this, not only DALC or DSIC, but any cases, you need those numbers so that you can understand the complication management and you can do the complicated cases in such scenarios. Dr. Samrat, sir, Dr. Uma ma'am,
Yeah,
your take on
I think
this.
I think I do agree that like I think Himanshu has written very nicely in the chat box that numbers don't create skill. I would disagree slightly. Numbers do create skill if you are doing it the right way. But what he has said next is lack of numbers guarantees insecurity. That is absolutely true. Sometimes you need the numbers to get your muscle memory on. Like most of the time, we do things on a reflex. So if you have numbers, then things that reflexes get much, much better. But the putting a number like this is very difficult. You cannot wait for, as Sujata said, 50 to start your practice. It would come with time, but you need to do it on a regular basis, periodic basis. It should not be in spurts like you do 2, 3 in 1 month and then wait, then get the next in after 7, 8 months. So even one per month, uh, you know, over a period of time would probably be good enough.
If you
But
can't,
Samrat,
then at least wet lab, Samrat. Wet lab can keep you going. The
Yeah,
numbers may not always see, every place may not be a major institute where you get so many cases every time, and it may be
yeah.
in spurts, you
Indication with,
know.
see, with DALC
Um,
indication is very important. So you will
yeah.
not get the
And
indication everywhere.
I
Right.
just
I
want
think
to
to
add one
do
thing.
them in the,
Can
sorry,
I,
please.
Shalini, please? I just want to add one thing. Always, what Prafulla mentioned, always see your poster. Number one, and always, if possible, see your recording of your cases. So each time it is right. Still, now I'm seeing my all my cases. So at least I make out. I did these things. If I do something, mera is problem hua. So you can make everything. I to preferably you see your cases, recording cases each time. Then it every time you can make out something new also. How to defining the thing and seeing the post-op is very really important. But what even the fellows resident, or if you do the two surgery, two suture also, you see your how your suture looks like tomorrow. I mean next day. What is the knot is proper or not, is the SS form or not? It is highly that's very much important.
it's not only next day, but keep following it up.
Following the exactly.
Sometimes if you feel your suture is good, but then you realize it is cut through after 1 month, then you
Exactly.
realize, oh, maybe my length was not okay or my depth was not okay.
Exactly, ma'am. And if there is something going wrong,
Yeah.
vascularization, I did the mistake, this thing, and seeing the recordings really is helpful to the refining your surgery skills and your reflexes too also.
And discuss with seniors, how it could be better.
Completely agree with the recording part, and also seeing great surgeons. I think I always watch Dr. Ritu's videos.
Oh, no, come on. It's okay. I made so many mistakes and I still make mistakes. So, it's like continuous learning. I think this current generation is luckier because they have somebody to teach them. We had nobody to teach us, right? We learned all by ourselves, reading here, reading there. And now, of course, you have all the videos, YouTubes, so many things are there.
Everybody puts their videos on YouTube and others, so it's good to watch.
Yeah,
One
it's a
thing what
continuous
Dr. Ritu said,
process.
yeah, one thing Dr. Ritu said is very important, to have communication channel with somebody, even if it's not a senior, even if it's your colleague, even if it's your
Anybody.
friend. Talk to people, because sometimes we go into shell, we don't talk to people, and when that happens, that's the most dangerous part of our career, that we can't reach out to somebody. Now all of us can have problem, all of us can have failures, but if we do not have courage to reach out to somebody, we that's going to scare the shit out of us. So have some channel where you can sort of talk to a person. It can be friend, it can be colleague, it can be senior, anybody. But I mean, if you have that thing, you will not get disheartened, you will not go into shell.
Mind you, all of us have made mistakes. All of
100%.
us. And and there's a saying, it says any surgeon who's had no problems has either neither operated or is lying. So
We
all
still
of
make
us.
mistakes, Dr. Ritu.
Sorry.
We still make mistakes.
We still make mistakes, and I remember most of you, I've called you up at any odd time, said, oh, I had this problem. I still keep calling up. So there's never an end to the journey.
I absolutely
I
agree,
think
ma'am.
learning never stops.
Yeah.
Yeah.
Can we go to the next question? It's
Yes,
close to
ma'am,
dinner
yes.
time now. Come on.
So, Dr. Apurva, our mentee, wants to ask this question. Dr. Apurva, you can unmute yourself.
Good evening, everyone. And the question is that how should a young refractive surgeon decides which new procedure to adopt, and how much hands-on exposure is enough before independently performing a new refractive procedure? Either it is assisted cases under supervision, like around 5 to 10 cases, or assisted plus partially independent cases around 10 to 20, or structured mentorship with graded independence, that is more than 20 cases, maybe.
Can we have the poll, please, Manjula ji? And mentors can also vote for this question.
So you don't have a mentor-mentee for refractive surgeries?
We do
Refraction
have some
as
panel questions, sir. We do have some panel questions. We are prepared, sir. Actually, sir, most of the people in the residency do not get any exposure to any refractive procedures per se.
no, what I
In
meant was
fellowship,
that this
sorry.
was cornea, right? So now refractive
Yes,
has
sir.
come in.
Yes, sir. Yes, sir. So we
And
only have one poll question left, and this is the last poll question, and then we'll have a quick panel discussion questions. Like we have four panel discussion questions. So we'll just take quick words on the panel discussion on those questions, sir.
So I think it's a 50-50. Half of the people think that it should be assisted plus partially dependent cases, and half of the people, okay, it's still going on. Okay,
Yeah,
so
you
the
can end it.
majority feels that it should be a structured mentorship with graded independence. So I would like to ask Dr. Prafulla sir, Dr. John sir, Dr. Gunjan ma'am, Dr. Rajshekhar sir for their take and opinion on this question. Dr. Rajshekhar Paul sir.
From refractive, you mean the classics and all, right? That we are going to do.
Cornea-based refractive procedures, sir.
Right. So see, like any of the skill-based thing, we have to have a because this is not taught in our residency or in our post-graduation. So we are completely new. Even when we are done our cornea fellowship, there also the refractive that we get is a touch if we are not doing a proper refractive fellowship. So in my fellowship, it was basically a cornea fellowship, but we had this refractive unit that we had posting. And so, if I want to do a proper refractive, yes, we need a structured, guided, proper fellowship to do it. Otherwise, we keep on learning. What I did was when we were posted in the LASIK units, we used to learn. See, it's more of a machine guided thing. More it is that in which patient what to do and whom not to do. More important is in whom not to do and whom not to touch. Because machines are available. We can do. This is not more of a skill based. This is more of a it's more of a mathematics. Like
Yes, true. Just to add on, refractive procedures. When I started learning LASIK, it was a microkeratome at RP Center, and I found it little difficult to learn microkeratome LASIK. Then femto LASIK came, and it made your life so easy. So femto LASIK is not very difficult to learn, but only thing is, as I said in keratoplasty also, femto LASIK or any LASIK, when it goes wrong, what is to be done. So that is what you learn by numbers and assisting people around you. And cornea based, now we are doing smile most of the time. Smile, yes, again, when it came, all of us had a learning curve. After 10, 20 cases, then we started learning. So definitely there is a learning curve, maybe 15, maybe 20, but it's not as difficult as keratoplasty, I would say. And pre-op screening, in which cases you shouldn't go for. That is the most important thing in refractive.
I 100% agree with Dr. Prafullo. See, basically, we are doing a full-time cornea fellowship. Though it's named cornea cataract refractive, we do the most of the cornea and cataract. Refractive part is really less. Even I've done almost 10 years before the Rajshekar told the scenario was extremely same. But some due to my own interest something, and we are keeps on observing our seniors, then we need a proper training, and you should know the machine to whom you know that is very important, and the things the to whom you should not do the basic the learn, I mean calculation part, and the biggest selection to whom you should do, to whom you should not do. That is the most important part. And the thing you need a proper I mean mentor, because it is not like the cataract patient that having the drop of vision, and then you can if you something going wrong, you can give an explanation. You have that issue. The patient who is coming for the refractive surgery, they have the sound eye, they have the 6 by 6 vision. So you are dealing someone who having the, then you should know the thing how that, and it need a proper training, and you should have some the learning curve and the weight lab proper before jumping on the patient. And we should be very correlate. Still, I have a very good terms with Dr. I'm thankful to Dr. Rupal ma'am, Dr. Partha Bisha sir, that still I have something going wrong to also, or something, then I have to ask them, this has happened with me, and so what should I do? Even after, I mean, almost 5 years, I'm doing the refractive too also. So you should be keep on in a loop and the things, and you should be and update yourself. So it is not that I'm doing the 4 or 5 cases and then suddenly do this. If you're confident enough, then then even definitely you should adopt the new technique, like that the Prabhu were telling that it is much easier once you are doing the, I mean, switch over to the femto one and then followed by smile procedure. So every learning having some learning curve, and you should know a proper, I mean, training and the mentor too also, and keep in the observing and the same thing. You should always see your old videos. Then if something going wrong, then you can follow up the things and you can rectify yourself.
Absolutely, sir. I think when not to do a refractive procedure is more important than how to do a refractive procedure. So, Dr. Gunjan, ma'am, your take on this question.
I completely agree with, ongoing conversation. And secondly, mentorship is important to manage the intraoperative and post-op complication. And we should guide the machines, and it should not be in the reverse. Machine should not guide us. We should be able to take decisions, and proper mentorship is very much important for the management of complications.
Thank you so much, ma'am.
I
So,
always say we should all know how to read our pentacams. I see a lot of people just want to do refractive, but they do not know how to interpret the pentacams. Just to
Exactly.
start from there.
So true, so
That's
true,
right.
so true.
So true, ma'am.
I agree,
And,
ma'am.
and one thing is that we should not blindly follow the, I mean, optometrist or your, I mean, staff what is doing. Even on still before setting, also you check the what is even also if you're doing the what correction you're doing, what eye we're doing, what is the power, everything should be checked by your, even before the before going to the surgery. That should be good habit. A rule of thumb should be in a specific refractive purpose.
So with this, we move on to our panel questions. We are done with our poll questions. So I request our mentee, Dr. Tanya, to unmute herself. She wants to ask this question to our mentors. Dr. Tanya, are you there?
Yes, ma'am. Good evening, everyone. I have a rather simple question to ask. I wanted to ask how to start research work in residency. I would ask Dr. Ritu ma'am, Dr. Gautam sir, Dr. Karan sir, Dr. Anujit sir, and Dr. Prasanna sir if they could please share their views on it. Thank you.
And easiest way, I think, when you want to start your residency, you all have thesis. So you learn the pearls, when you're preparing the thesis protocol, how to do the review of literature, how to know what's the lacunae. That gives you, and how to know your statistics. Very important to know what test to apply, what is relevant. And the thesis is an exercise for you to, is initiating you into research work. And if you really want to go into publishing, the easiest thing is to start writing your case reports, though most of the journals do not accept case reports at the moment. But, I mean, at least IGO has IGO case report. So analyze, have an analytical and a critical thinking mind that why this patient is like that and why this is not working in this patient, what's so unusual about it, how to plan a study. So that's how you can start, initiate into residence and continue to learn, continue to be abreast with what is happening the latest. Of course, when your residency, you are clearing your basics also. It's not that you forget your basics and know what's happening the latest and speak the hi-fi terms, but know your basics, continue to learn, and start with publishing case reports, and must try and get a paper out of your thesis work. At least as long as I was there in Maulana Azad, I used to see that every candidate would publish at the end of the thesis. So that's how you initiate it in the research work.
Absolutely agree, ma'am. Thank you so much. Dr. Gautam sir, your take on the question, how to start research work in residency.
Research, it is very much important that one should be inclined towards research, and every effort should be made to promote the inclination towards the research. That is the most important here. In the government, like what we have faced in our residency, that there are no facility of even the slit lamp is hardly available, and patients are also very less. So it is always difficult. But as ma'am said, the research, the thesis work. So do your thesis genuinely. That is most important. Otherwise, what happens that someone maybe type others work like that. That also happens in the residency. But do your thesis work genuinely. That is most important thing, and this is how one can initiate your inclination towards the research in your residency.
Thank you, sir. Do we have Dr. Anujit with us? He has many publications and research work at a very young age. So, if he can guide our residents on how to start research work in residency, Dr. Anujit?
Thank you, Dr. Lippi. I would just echo what ma'am and sir said. Just one point that I would love to add is reading journals has become very underrated. Reading journals does help a resident figure out how to frame methodology, how to frame a discussion. We can go with our national journal, IGO, for example. Most of what I have learned is by reading other examples of the similar topics, especially when you're doing case series, is how to present one case after the other in the section and how to actually discuss what is relevant in literature versus what we are finding in literature. So the other way of getting better is to just keep reading. IGO has monthly issues. There are many journals, state journals, who have quarterly issues. So there's a lot of resources out there, and that's the only thing I feel that would benefit beyond what ma'am and sir said.
Thank you, Dr. Anujit. Do we have Dr. Prasanna, sir?
Yes, Lippy. I was just typing in the chat box. I think I echo with Anujit on that point, and also documentation. So any case that we see today as the seniors were rightly guiding us, young ophthalmologists, documentation is the key. And a simple smartphone camera, if you are not able to have access to high gadgets, make sure you document your findings. And that itself would serve as a great precursor to start your journey as a photo essay or an ophthalmic image, case reports, and then slowly move your step ahead of the ladder through original article, getting your thesis out. And that's the way to move forward, is what I would say for the young ophthalmologist. Thank you, Lippy.
Thank you,
Dr.
sir.
Rolika, Dr. Rolika, if we can have your opinion also, because you have a lot of research work. Rolika, you there? Okay, so I think we can move on to the next panel questions. So I would like to ask our mentee, Dr. Pragya, who wants to ask this question. Dr. Pragya, are you there? Can you unmute yourself and come to the camera? Yes.
Yes, ma'am. So my question is, how should one decide where to do cornea refractive fellowship or SRship, and what points should be kept in mind? I would like to ask this question to Dr. Namrata ma'am, Dr. Uma ma'am, and Dr. Gunjan ma'am.
Dr. Namrata ma'am? Ma'am, if you're there. Dr. Uma ma'am?
Yeah, actually, this is nowadays there's so much of knowledge which is available on the internet. Obviously, you will be talking to fellows who are already working in big institutes or SRs, like if they are working in AIMS, Guru Nanak, in what do you say, Shroff, or any other institution, Arvind. So you know what kind of mentorship is available there, who are the faculty, how much is the the work that is available medically and also surgically. So I think by interacting with the already existing fellows and SRs, and depending on what is in your mind, nowadays lamellar surgery is the glamour part of it. But yes, you need to know medical cornea, you need to know medical aspects of refractive and cornea, and then you learn the surgical aspects of it, because some fellowships will give you a lot of medical, lot of infective keratitis and other stuff, and there will be some fellowships which will, and observerships, where you can learn the surgery aspects of it. So one has to keep that balance in mind. What are you looking at? You should learn both the medical and the surgical aspect. It is not just the glamour aspect of it. Like when I attend conferences, I see youngsters discussing how many dives have you done, how many DSECs have you done. That's not the only thing that you need to learn. It is the overall aspects of it that you need to learn. Ultimately, what does a patient want? Patient wants vision. He wants a clear cornea. So where are you? You have to work towards that. So it's not just one aspect of it that you keep in mind. So a holistic view is important. Of course, your need, what are you looking at? So like Dr. Vikas has an excellent fellowships. I've seen how his fellows do. So it may be a small place like that, or it may be a big institute like RP Center. There is a lot of passive learning, lot of lateral learning. So you just look at your needs, and of course where you get, and if it is inadequate, you go ahead and do further observerships and training. So I think that would, I don't know if that answers your question.
Thank you so
Yes,
much, ma'am, for
100%
your
agree with you.
insights. Dr. Namrata, ma'am, if you're there, Dr. Namrata, ma'am. Okay, so we can take the opinion from Dr. Gunjan.
Hello. I would like to add that I completely agree with Dr. Uma Madam, and I would like to add that also consider your family life. We can't leave everything and pack your bags and go. We have to balance our personal life with learning. And secondly, surgical exposure should be good, and you should make your priorities clear. Yes, like I want to do this thing. I want to work in a institute. I want to do a private practice. I want to do a government job in future. You should have some idea where do you want to work in future, and these, after considering these point, you can decide your place of fellowship or SRship.
Thank you so much, Dr. Gunjan. With this, I think we will
We'll
move
move
on to
on.
the next question. Yeah. Total, if
So
you
I request Dr. Ranu Sharma to ask the next question.
Good evening, everyone. So, my question is, with a growing market where everyone is doing refractive surgeries without proper fellowship, what does the refractive fellowships add so that we think we should join?
And the question is to Dr. John sir, Dr. Sujata ma'am,
Dr. Prafulla sir.
Dr. Prafulla sir.
I think
Because
we've
this is very
already
important. This is
discussed about.
yes, ma'am. Yes, ma'am.
Yes,
You please, ma'am.
John, go
Ma'am,
ahead,
you
go
please,
ahead.
ma'am. Yes, ma'am.
No, I was saying that we already discussed that surgically skill-wise is not a big thing, but we should know when to do, when not to do. It is not only the surgical part, the topography map analyzing and deciding whether to do or not to do is a big thing. Uh, I think without proper fellowship, people are doing. I don't need a long-term fellowship. Like, for example, all of the people who are in the panel, I don't think or the senior person, they have done a refractive fellowship. It is most of the time it is a cornea fellowship, but there are refractive. Does not refractive surgery was not there as a separate entity maybe 15, 20 years back. Now there are a separate refractive surgery. I think we can do without a separate specific refractive surgery. Most of the cornea fellowship also offer refractive surgery exposure. Now in LVP also we have a separate refractive surgery, but still the cornea fellows do so, and it is not pure refractive. Most of the time it is cataract plus refractive surgery.
Yeah, ma'am. I 100% agree with you. Even 10 years back, when we completed the fellowship, we have a zero exposure, surgical exposure fellowship. But once we joined the Shankar Natal as a junior consultant, associate consultant, so even that time also, we honestly we are not that much flexible when we are not allowed to do these things. But we are really, you should keen for the things. If you really wanted to learn the thing, we keeps on observing our seniors, they are operating up, and we see the and we always, and what the madam was telling, your mind should be clear to whom you should do and to whom you should not do. That is the most demark, that thing is very clear conception. To whom you should not do the refractive, that is more important to know. And every eye is different, every patient expectation is different, and which procedure is the best for the patient, you should judge. That judgmental power you should be there. And the you no need for the your extended 2 years or 1 year fellowship like that. If you have a proper, I mean also refractive, I mean FECO fellowship too also, if you have a sound conception, sound hand, so you need a proper mentor and the learning curve too also. Because if you just, and there are a couple of cases they will just ask you to 1 or 2 flap on the good side followed by, but you should join some of the center or be the attached to the some initially, at least during your learning phase or your lock phase of the learning of the refractive surgery, where you can also exposed to see the different surgeon operating. At least every week some of the reflex, your reflex should be prepared enough. So that's actually almost last 5 years, no one has just give you the, that's like a facotaning standby us to do the, oh you are doing this case, you are doing, because individual have to decide. We go through it, went through the training to some of the, now lots of centers are there, they are giving the short day, 2 days, 3 days training, and you can observe their observation, then you can still start the thing. but there always should be, there is no shortcut way of success. There is a learning curve is there, and preferably for the new, I mean the those were now you're, I mean new, I mean the just pass out PG, or those who they completed the SR job fellowship, for you just join some of the center where they have a balance, because this is the part of the things you are doing, the seeing the I mean doing the cornea as well as the refractive too also. Definitely it's a part of the, I mean new learning too also. You should do this. You should not discourage the thing. You should learn the thing. But join some of the center, at least you should have a good exposure. Every week you can see something, then automatically you can learn the thing, how the every process learning. And if you have some of the issues, you can discuss with the senior, or always there is a, I mean the someone be there as a mentor whenever, even also still that I've already discussed this, I mean shared the fact, even also still I have some of the issues we discuss our my first mentor Dr. Rupal Shah ma'am, or my fellowship mentor and Dr. Partha Bishop said too also. So that's it.
Thank you, sir. Do we have Dr. Prafulla sir with us?
Yes, yes. Could you just repeat the question? I think I missed a part of it.
So, with the growing market where everyone is doing refractive surgeries without proper fellowship, what does the refractive fellowship add? And so that we think we should join. This is a question
Well,
from our resident.
I would like to little differ from the previous panelist. You know, fellowship, I feel nowadays you have to do fellowship from some institute. Better to do it from some reputed institute, because nowadays the patients are becoming very smart. They search for your name, they search in Google, they see where are you doing, what are you doing, and then they come to you. So when you have done a fellowship, that give you some authenticity. Even if something goes wrong, the patient will not be after your life, because he knows that yes, this is a well-trained surgeon. If you haven't done a fellowship, you may do surgery, you may do a lot of things, but if you land up in any trouble, then you find it very difficult to refer the patient to somewhere, discuss with somebody. So for doing refractive procedure, please do a fellowship, at least 6 months fellowship with somebody who is an expert refractive surgeon or in some good institute. That will definitely give you some edge. And if time permits, I'll share an incident. I know a practitioner, who had primarily done fellowship in retina, but he did a FICO refractive because he wanted to paste that degree in front of his office so that the patient knows that yes, my surgeon has some refractive exposure also. So doing fellowship will definitely give you an edge. So you should try to do a fellowship.
But why should you do a fellowship? You can be an influencer also and still do a good refractive surgery practice. Nowadays, there are
agree,
so
ma'am.
many
In
people
today's
who are
time,
only
yes,
YouTubers. Who are
social
YouTubers,
media
they
time,
may do
ma'am.
one or two refractive surgery and then they keep posting, this is the way. They don't even have the machine. They don't even know the basics of machine. But YouTuber will do a better job than Prafulla, what you and me can talk about.
But
I
no
completely
comments on
agree, ma'am.
that.
I
Yeah.
completely agree with this
Yeah,
point.
because they promote a certain procedure, and what is your success bottom line at the end of it, So they are doing much better job. Sometimes I feel quite useless in front of them. Yeah.
But ma'am, the only point is, by doing social marketing, you'll find one or two people have succeeded hugely. But by getting a good training, you will find
No,
100
no,
other
no. There is
surgeons
no
they are doing.
shortcut to a good training,
Yeah.
but I'm telling you about the current era. That's all. It's the current trend.
See,
Thank you so
the
much.
term growing market underlines everything. Where is the market? So when we believe in a market and when we believe something saleable, then the things are different. So even if you have a very good fellowship, you are still you would be very confident, you'd be doing a very good job. But if you do not bend to the market forces, you still may, like as Dr. Ritu and Praful also mentioned, you'd still be trying to, feeling less in front of those who have captured the market.
Okay, so with this, we move on to the last panel question for today. I would like to ask our mentee, Dr. Renu, to please ask this question to our esteemed mentors. Dr. Renu, are you there?
Uh, Good evening, everyone, and thank you so much for such an insightful session. I would like to ask how are international observership and fellowships for cornea refractive? And are there any short-term fellowship and option for skill enhancement, or they should be done for routine fellowship option also?
So this question is for Dr. Samrat sir and Dr. Rajshekhar. If you can add your comments, please.
I always believe that, not international, if you do a fellowship from one institute and if you go to another institute of the same stature, whether it's national or whether it's international, it gives you a different perspective. And internationally, I think I've never gone into international fellowship, and that's been one of my things that I've not been able to do. But I think that gives you a different perspective of how we look at a subject and how we look at the patient. Like just at the beginning, Professor Namrata did mention that how John Dart said that, how important he thought therapeutic PK was compared to a lamellar procedure. And we think it in the opposite. So it would give you a good perspective. And on the other side, to market forces, I know a long time back, at least in the 90s, I don't know if the trend is still there. In Calcutta, the trend was to get a FRCS, uh, that FRCS degree. Now we all know that FRCS is an examination, but the market forces in Calcutta in the 90s
41.
had a lot of respect for someone with a foreign degree. Now also we also look outwards to the west. So a foreign degree would definitely probably add something to your visibility, and it would also, in a much more academic sense, educating sense, would give you a perspective that probably would not be there in many of the Indian institutes out here. A different perspective, which would always be rounded. I remember Richard Feynman, most of you would have heard, who was a Nobel laureate physicist. He did one of his doctorate from Princeton, and then he went to Caltech. And they said, why are you going from Princeton? Because that's one of the mecca for physics. He said, no, I just want to go there for a different perspective. So the different perspective is important when you think, when your career is going to go for a very, very long time.
Just to add up upon what sir was saying, that international observerships we cannot substitute. It should not be taken as substitute for any fellowships. Again, at the same time, a 1 year, 2 year international fellowships. If we are planning, then we must keep in mind what we are leaving behind. We are leaving behind our place. We definitely gain a broader perspective. We might gain a broader outlook. There is a, but it doesn't apply for all. I guess we have family issues. There are good scholarships, but again, monetary issues. Again, settling in a new place. So yes, from my perspective, will be to enhance skill. It is definitely the fellowships that we are doing in Indian subcontinent. We have got wonderful institutes doing all kind of cornea, be it refractive or cataract. In fact, people are coming from different countries in our places to learn such things. But yes, international fellowships do give us a sharpen our vision, what we are doing and what mistakes, like as I was saying, market forces. At least I have seen places where these market forces, at least they don't influence, like Professor Busin, he conducts his DALC workshops. There they teach what they were teaching us what they were teaching 10 years ago also. So we get a perspective difference. That's it. So yes, international observership is definitely good, but it's more of an optional, and it should not be taken as a substitute for a full-term fellowship that we can do in England.
I think
agree to you.
perspective, Sunandini, it's exposure is one. You get to know a lot of people, plus you get a different perspective, and you look at it from the other side. Like it broadens your vision a lot. It's not just that your skills can be homegrown also, but it's just a perspective, and you also get an international exposure. So that's one.
Yeah, I
I
100%
completely
agree with
agree
the
with
Uma ma'am
this,
and
ma'am.
these things. The options should be open. It should not be that we should be open. Options should be open. In spite of that, at this age also we are planning to do the things also if it is possible like that. The options should be open.
I
I
think
think you
it also gives you
actually
the
learn a lot as to, especially in international fellowships, their way of working. I refined my cornea skill when I went to Wills. Though I was trained at RP Center, But then it's only when I went to Wales and I saw their way of working. I went to Canada, I went to Mark Terry. So, it's actually basically when you see these giants and good places, see how they document. We somehow lack the part of documentation. So you pick up their good things and how they go into analysis, their research perspective. And so whenever you get a chance, international fellowship should definitely be considered.
I agree with you, ma'am. Dr. Himanshu, sir, you want to add something? Sir has been writing on the chats and giving all
No,
his
I
insights.
no,
Yes,
I
sir,
just
please.
want to say that, especially the youngsters, you might be appearing for ICO fellowships and those kind of things. See, doing such kind of observership, international observership, are not going to give you anything hands-on. So that's for sure. You want to understand that. But when you want to do such kind of thing at very beginning of your career, it's very difficult to earn respect from that mentor. You end up fly on the wall kind of thing in front of them, and you may sort of go and see new culture, and that's absolutely great, and it's very nice. You learn a lot of things by going there. But once you are based, I mean, you have got a base in your career, you have stabilized yourself, and then if you go, you get much more out of it. You get huge networking opportunity. You get to meet people. They respect you much more because you are already an established person there. So you get actually more out of that. So if you have a choice that can you do your FIC or fellowship little later on and not immediately after your fellowship, I would say use it if it's once in a lifetime, and if they are sponsoring you, use it a little later on rather than the early part.
Thank you so much, sir. We
Himanshu,
also have
some
one more
some
question.
places they give hands-on because I did two. One is in Melbourne, Australia. One is ICO fellowship in Germany. Australia, they give hands-on. It is not that not US. It is difficult, but some places they give hands-on.
Yeah, I think Sujata, we are talking about in general. So it's not about one place. 99.9% would not be giving. So let's be aware of that. It's an observership which we are talking about. It doesn't matter because you're not going there for hands-on training. Going to an international observership for hands-on training is not your aim. Then you're looking at the wrong thing what you're aiming at. You are going there to learn a different culture, different perspective, and the enthusiasm about their own. I mean, one thing which we take a huge pride in is our jugaad culture. But I don't think always we need to be proud about jugaad part. Many times when we see these people, these experts, they are so good at one particular small thing, and they are okay to say that I don't know about other thing, and I'll get back to you. And knowing them doing their work so meticulously, as Dr. Rita was saying, that they are so good at small thing, picking on these small thing and those small habits is something which I would pay my money to be part of that.
Thank you so much, sir, for your insights. We
I
have
think
one question for our
currently the
mentors.
international fellowships are more useful to be put on Insta and Facebook. That's what I feel primarily. Yeah.
Okay, we have one question from our mentee, Dr. Ayush. If you can unmute yourself and ask your question to the mentor you want to ask. Dr. Ayush, if you're there.
Hi, good evening to all the delegates. My question is a bit multi-layered and parts of which have been already been answered. My question is now as a senior resident, I'm finishing my bond very soon and I wish to apply for a fellowship. Now there are institutes that offer only cornea, there are institutes that offer only refractive, and there are institutes that offer cornea and refractive altogether. A constant review that I've been getting is cornea refractive may usually the refractive surgeries take a backseat because the hands-on exposure is quite limited. And my next question to next part of the question is, will it get overwhelming to learn two separate fellowship programs, trying to learn it all at once in a 3-year course? Or do we have to restrict ourselves or, supplement us with the 6 month fellowship later? So this is my confusion because it is not allowing me to exactly reallocate which stream should I go for, or if it would be too much to learn, and I have to give in a lot of my time, like maybe a lot of work hours, and a lot of institutes do have long OPD hours and OT this thing. So it might also affect day-to-day life as well. So my question is to Dr. Himanshu, Dr. Gautam sir, because SNC in itself also offers cornea refractive courses. So my question is this.
So Gautam sir, if you're there.
Can you repeat, please, the question?
So he wanted to know that most of the fellowships who offers cornea and refractive fellowships together, the refractive part over there is a little less than the cornea part. So he wanted to know that whether it is worth to do a cornea refractive fellowship or two different fellowships, one cornea and one refractive, maybe for shorter duration of period, thinking about the time duration and planning.
The refractive surgery do not need too much of the surgical skills as much as the other corneal procedures needs. So like decision making is more important as this as discussed before. So I think the short exposure to refractive along with the cornea fellowship is always good. I think what we offer at our SNC that we in third year we allow them to do LASIKs and all, means the refractive hands-on refractive procedures. And what our approach is to go step by step. Like initially we just let them to wash the flaps only, and then what we do here is we just ask them to hold microkeratome and put it over the eye. Do not cut, just uh, apply the suction ring and release, and then we initiate the procedure. So step by step learning, and I feel that it is sufficient for them what exposure we are giving. So my take on this that we can have both together, and we need not to do exclusive refractive fellowship for that. I think it is sufficient what we are offering.
Thank you so much, sir. Dr. Namrata ma'am, your take on this, whether we should.
I think cornea and refractive go hand in hand, and I feel that when you're doing, you should do both, because a lot of refractive problems are also corneal, and a lot of corneal procedures are also refractive, and then refractive encompasses cataract also. So we at RP Center do give senior residency, and I know at GNEC also there is senior residency, which gives an exposure to both cornea and refractive. As far as refractive is concerned, I think, like Gautam said, and I quite agree with him, for certain procedures like LASIK, etc., you really don't require too much of skill. The decision-making part is the one which is more important. But for corneal surgery, of course, you do require a lot of skills, and every corneal case is different, which is unlike a refractive case. Once you have decided, every LASIK would be probably similar, or every smile or every lenticular procedure will be similar. But every ocular surface case, every corneal case is a little different. So, and I don't think it is overwhelming to do both. It kind of complements each other, helps you to understand the whole cornea as such in a better manner, because that also contributes to so much of your refractive part. And of course, learning phakic IOLs is something which should be done. And when you're doing cataract, then you might as well learn your phakic IOLs as well, because that again, all these three things, cataract, cornea, refractive, they complement each other in some way or the other. So I think both should be done.
Thank you so much, ma'am. Dr. Himanshu sir, your opinion on this.
I feel you're unnecessarily getting into which place is better or something. I would rather say choose a mentor. Your fellowship is not just about learning the subject. Your fellowship is you are as good as the main mentor you get. To get a good mentor is not very easy, and it's a luxury. So if you're able to get a good mentor, I think you should be fine with whatever you choose. Don't worry about, as Namrata said, it's not about, you can learn all these things and you will be able to learn all these things together, and it's not as difficult. But
Completely agree with sir. Your mentor is what
is most
yes,
important.
ma'am.
So
Yes,
as a
ma'am.
mentor,
Definitely,
I feel that whenever, say, I get a senior resident, and I know that all my senior residents would vouch for that, I always feel that at the end of their senior residency, they should be able to do everything that I can do. And I really tell you, they do it much better than me also when they leave. So they're that confident. I mean, there should be nothing which, I can do and they cannot do. I mean, it's not done. And as far as training is also concerned, we never, I mean, at least I never try to give everything sequentially. So from the day one, I mean, you are on the run. I mean, you have to, you have to do everything, the decision making, the surgery, the steps of the surgery. And I always make it a point that at least a couple of cases I will assist them, howsoever heavy my OT may be. So that is what I make it a point to do, because they also have to learn. And that is it. I mean, that's what John Dart told me when I went for a fellowship in Moorfields, that everything that I can do, you should be able to do it. And that is what I also abide by as far as my residents, senior residents are concerned.
Thank you so much, ma'am, for your insights. Thank you all the mentors for these insights that you have given us. And with this, for the interest of time, we will move on to the keynote speaker with Dr. Tushar Grover. Dr. Tushar, if you can please share your screen and give us the keynote talk for today on sodium hyaluronate for dry
Thank
eye.
you, Dr. Nani. It was wonderful listening to all the mentors, and I think this platform will actually encourage the mentees to be able to ask more questions, because now they're able to see how willing to guide, how willing to help all the mentors are. And I was just keenly listening to everybody. It was a really, really nice session and very well thought out. So I'll try and be quick. I'll try and let everybody get to dinner in about 10 minutes. So I'll talk about optimizing dry eye, and in this particular case, we'll put a little more emphasis on sodium hyaluronate. So first, I'll talk about why we need to optimize the frontline stabilizer that we have, which is essentially the lubricant, and then the backend modulators, by which I mean us treating the etiology of the condition. So why do we need to optimize dry eye? Because we do know that it's the most common condition that we see in our practice. I don't think it's underdiagnosed now, but it is definitely under treated. It is not adequately treated, is what I believe even now. And as we know, it's not just about tear film instability or deficiency of the tear film aqueous layer. It's a lot of other things. It's a vicious cycle which includes hyperosmolarity, includes apoptosis, includes inflammation. And any individual that enters this vicious cycle by any of the etiological agents, the cycle then self perpetuates even after you remove that offending agent. The Deuce 2 had laid emphasis on the fact that it's not just aqueous deficient or evaporative dry eye. There is a lot of continuum, there is a lot of overlap, and the management has to be to restore that homeostasis. Deuce 3 has also reiterated that it is also focused on mainly treating the etiology rather than just looking at it as aqueous deficient or evaporative dry eye. So starting out with the frontline stabilizer, with the lubricant, when we look at these kind of charts, it sort of confuses us and we don't really understand the mechanism. So I thought that for this presentation, I'll just simplify some of the important points in relation to sodium hyaluronate. So when we talk about, hydration and water retention, it essentially means that sodium hyaluronate is acting like a sponge, because of which it is able to absorb that water, and therefore you have moisture being retained on the ocular surface for much longer. We also talk about viscoelastic properties. What is important here from the point of view of sodium hyaluronate is that it is adaptive in terms of viscoelasticity. So when you have a blink, it thins down, that viscoelasticity reduces. When the blink is over, it restores that thickness. So therefore, the comfort levels are higher, and therefore the retention is higher. We also hear mucoadhesive property, which simply means that the complex molecule of sodium hyaluronate essentially binds with the mucin layer of the tear film and with the glycocalyx of the epithelium, therefore enabling retention on the ocular surface longer. And because of these factors, because of the bandage kind of an effect or a padding kind of an effect, when you see an individual like this is day one post LASIK dry eye. Because of this effect, you're able to allow healing of the epithelium that lies underneath it. So the Deuce 2 report clearly states that there is not enough randomized data to say that one lubricant molecule is superior to the other, and that is what we should be following. In terms of biomechanical properties, the important points which sodium hyaluronate is good at is that water retention is quite long. The adaptive nature with blinking that I just spoke about, and the fact that it is able to help in the healing of the corneal epithelium. Now, what does Trehalose exactly do? Trehalose, because we see all these complex definitions, and I think just to simplify it, it's a complex sugar which surrounds the corneal epithelial cell, and it prevents the desiccation from happening. So normally when you have a corneal epithelial cell, when you expose it to a dry environment, because of dehydration, because of the uh, other factors, apoptosis sets in, and the cell desiccates. This complex sugar prevents that from happening in the presence of dehydration. So this is what Trehalose do, and that is why they are used in a combination, and therefore they have been found to reduce dry eye signs and symptoms. This particular study is in relation to post cataract surgery, and you can see improvements in the subjective symptoms in terms of the OSDI scores and in terms of the objective signs in TBUT and other signs as well. And it has also been documented that the combination is more effective than just sodium hyaluronate alone. You also, as we know, have the option of the gel in moderate to severe forms because of prolonged retention. It is more effective in these scenarios, and you're able to reduce dosing frequency and therefore enhance compliance. And this also leads to improvement in dry eye signs and symptoms. Now, practically, which lubricant should you be choosing? Essentially, it depends on the severity of dryness that you have. When somebody has mild dryness, you can go for a low viscosity lubricant, which can also be a CMC 0.5% or a sodium hyaluronate 1%. Cost can also play a factor here. When it is severe dry eye, you would go for something which is high viscosity, such as sodium hyaluronate 0.18% or CMC 1% if cost is a factor. It is important to know that when you have a high viscosity lubricant that you're giving, you are going to get greater symptomatic relief, but you'll also have more blurring. And now we have lubricants with lipids in them. So with somebody with predominantly evaporative dry eye, you can consider one of those as well. So now I think the other thing that is really important is to look beyond lubricants, because lubricants we all give, but it's important to look at the other aspects of it also. It's important to document the symptoms that an individual has with any of these questionnaires. The OSDI is more commonly spoken about. It's also described in the DUES 3 report. But there are other questionnaires also which are validated and shorter. So if time is a constraint, you can use one of them also to document symptoms and monitor symptoms as you progress in the treatment. It's also really important to look at and treat the underlying cause. The image that you have on the left is drug-induced cicatrizing conjunctivitis because of somebody using oral gliptins for a long time. So in that case, you have to discontinue the offending agent. What you see on the right is pemphigoid, and the individual needs long-term immunosuppression here. So these things are really, really important. And when you have these kinds of immune-mediated dry eye, very severe dry eyes, again, you need to look for the etiology and treat that. For example, Sjogren's, rheumatoid arthritis. And also you need to treat inflammation in these cases with cyclosporin or lifitegrast or, of course, topical steroids in short courses whenever they are needed. In these kinds of extremely dry eyes and severe ocular surface diseases, scleral lenses are also extremely helpful because they create that fluid reservoir between the scleral lens and the corneal surface. Punctal plugs also can be used in some of these scenarios. The other thing that's really important to evaluate is MGD just by looking at the appearance of the glands and looking at the expressibility of those glands. You also have these fancy diagnostic equipments available now where you can look at the lipid layer, you can measure the lipid layer thickness, you get partial blink analysis, you also get imaging of the morphology of the meibomian glands, and you get to see what kind of dropouts there are. Are these modalities essential? I really don't think so, because you can still evaluate and treat without all of these. These just give you a slightly higher understanding of the chronicity and the severity of the condition that is there. So very important to treat MGD as well, which can be done with warm compresses and manual lid expression. And that works very well. The chronicity of this condition needs to be explained to the patient. You have these other modalities available as well, such as these heating eye pads, the thermal flow treatments, which are primarily useful in people who are not compliant with conventional warm compresses. Then you have options like the LipiFlow thermal pulsation, you also have intense pulse light, which again should be advised in a sequential manner. Somebody who's not responding to conventional therapy, then you can move on to the next step, which can be LipiFlow or intense pulse light or potentially even both. So to summarize, dry eye is highly prevalent. I think in this group, definitely not underdiagnosed, but it is often inadequately treated. Sodium hyaluronate and trehalose improves objective signs and subjective symptoms, particularly in moderate to severe dry eye. Lubricants are the first line, but it is extremely important for us to look at the underlying cause and treat that. And it's also extremely important to treat MGD because it is more common and you need long-term treatment for that. Thank you.
Thank you so much, Dr. Tushar. That was really nice. And your presentations are really very mesmerizing. I have listened to you in conferences also, and your the way you speak in your talk is very captivating for the delegates and the faculty. Thank you so much
Thank you so
for
much.
this
Thank
talk.
you.
And for our viewers, this webinar was sponsored by JB Pharma. And with this, we come to the concluding conclusion of our webinar. And I would like to take a um, uh, closing remark from our chairpersons and our mentors. Dr. Sujata ma'am.
It was a nice experience because I think this is the type of meeting will help the younger generation because all the mentors and everybody came with their own experience. How do they handle? What is the scope of future? So I think more of this meeting is required for the younger generation. I really enjoyed it. Thank you.
Thank you so much, ma'am. Dr. Ritu ma'am.
Yeah, I echo what Dr. Sujata said, and I really felt nice. And I think these kind of webinars reduce the communication gap, and it really gives opportunity to all the youngsters to ask any question, unhesitatingly. I was very happy, and thank you for me being there.
Thank you so much, ma'am. Dr. Himanshu sir.
Yeah, thank you. I had a great time, and I wish Yosi keeps doing such kind of thing. I just have one complaint. 18 minutes of introduction cannot be accepted from Yosi. You guys should be the trendsetter. You guys should say no introduction. Everybody knows everybody. Let's move ahead. Right? So we can save some. I don't think everybody loves the program. Everybody has given a lot of things for this kind of thing. I think Yosi can take a conscious call that, okay, no more introduction. We will just go and start. Sorry, but
Thank you. Thank you so much, sir. Dr. Gautam sir.
Thank you so much, Sunandini, for making me part of this wonderful webinar. And I enjoyed a lot. The most beautiful thing I must say is the interactive part. Instead of being like presentation based, I loved much. Thank you so much.
Thank you so much,
For
Gautam
inviting.
sir. Dr. Samrat sir.
It was wonderful being here, and I would like to echo Himanshu. No introduction and no summing up by mentors to eat up more time.
Thank you so
We'll
much,
make
sir.
sure, sir, the next time when we have the intros, we will just simply go as what the person's name is and where they're from. So we'll make sure that we execute that. There might be
Yeah,
a
that's what.
slide everyone need to read, and we'll just give the affiliation.
Yeah, that's what I sent to Sunandini when she
We'll
asked.
do.
Thank you so much, sir. Dr. John sir.
Absolutely.
Yosi and Sunandini for incorporating me. It's a great learning. And definitely, I just echoes with this what the Shamrat sir and the Himanshu was telling. And it's really, and also this is very without any slides, something is very much interactive. We learn so many things from each other. That's a really hats up to the mammoth work by all of you were done. Thank you very much.
Thank you so much, sir. Dr. Rajshekar Paul.
Actually, I learned more than I contributed. So it's a great concept, and I hope to contribute in future and same thing. Thanks.
Thank you so much, Dr. Gunjan. You're on mute.
Thank you so much, Dr. Sunandini and Yosi team for inviting me and having me here. It was a great learning experience and I enjoyed it very much. I have learned so many things. Thank you so much.
Thank you so much. And over to the organizers for their closing remarks, please, Dr. Anuji, Dr. Rolika, Dr. Prasanna, please.
I think I'll speak on behalf of Anujit, Prasanna, and myself. I think we will summarize it for all of you. That Sunandini, you've done a great job, and Lippy as well. And we really thank all of you for staying back on a night where I think a lot of people would like to go and enjoy with their family members. So thank you so much for staying up with us. Thank you to the mentors and the mentees. We really, really thank you from the bottom of our hearts for joining us. Thank you so much. And Sanandini, love you for organizing everything. Thank you.
Very
Rolika, for
nicely
the
organized.
opportunity.
Sunandini, very, very nicely
Thank
I
you.
organized.
think let's
Thank
give
you.
them a
Good
big
night.
hand,
We
for
should have give
having
applause for the
organized.
Sunandini. That's a
And
mammoth job. It was
dear
very
dear
good.
mentors, we would definitely like to have you with us physically at YosiCon as well. This year will be our third annual YosiCon, and we all YOs are here because of mentors like you. So please do join us at YosiCon as well this year and bless us. Thank you. Yeah. Anuji, do
Okay,
you want
That
to?
was a cute ending. Thank you so much.
bye-bye.
Thank you, everyone.
Dr. Anujit, your,
Anuji, do you want
closing
to
comments,
quickly?
please.
Yeah.
Thank
No, I
you.
think we've had a lot of
Thank you.
closing comments.
Thank you.
We can
Thank you.
wrap
We
up. Thank you
can
so
have
much.
Photo,
a
photo,
Thank you,
photo,
everyone.
group photo, group photo.
If everyone
With
can just
a
switch
group
on
photo with a
their
Vayo sign, ma'am.
switch
With
on
ma'am with
their
the Vayo sign.
all
Yeah,
right. So
and we would
The
also like to
mentees, please,
thank
with the Vayo sign.
we also like to thank Manjula ma'am and Numerotech team.
yeah.
Yeah, Manjula ma'am and Numerotech team, thank you for the seamless streaming. And
Yeah.
can you please take a photograph as well?
Anujit will do it, I'm telling you.
Anujit. Okay, fine.
Sure, doctor. Thank
Thank
you,
you,
doctor.
thank you,
Yeah,
ma'am.
Thank you, doctor.
Okay.
Thank you, Manjula
Thank
ji.
you so much,
Thank
everybody.
you.
Thank you so much.
Bye-bye. Thank you.
Thank you
Good
and good
night.
night.
Have a
Everyone,
good
good
night,
night.
everyone.
Good night.
Thank you. Bye bye.